We now go into public session. Is that agreed? The purpose of this morning's meeting is to hear of the insights into the operation of our national oral health policy. We have already had a meeting on the 15th of May where we heard from the Irish Dental Association and the Faculty of Dentistry at RCSI. So this morning we have the opportunity to hear the views of officials from the Department of Health and the HSE, along with representatives from the Oral Health Policy Academic Reference Group, which was established to help provide the Department of Health with independent research data and policy advice to improve oral health in Ireland. So on behalf of the committee, I would like to welcome this morning Mr. Fintan Judge, Principal Officer, Department of Health, Dr. Dymphna Kavanagh, Chief Dental Officer, Department of Health, and Mr. Fergal Goodman, Assistant Secretary, Primary Care, also of the Department of Health. From the Oral Health Policy Academic Reference Group, Dr. Alison Dougal, Professor Brian O'Connell and Dr. Jacinta McLaughlin. And finally from the HSE, Mr. Pat Healy, National Director, and Dr. Joe Green, National Lead for Oral Health in the HSE. Good morning, and you're all welcome. I wish to draw your attention to the fact that by virtue of Section 17(2)(l) of the Defamation Act 2009, witnesses are protected by absolute privilege in respect of their evidence to this committee. However, if you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any person or persons or entity by name or in such a way as to make him or her identifiable. I also wish to advise you that any opening statements you have made to the committee may be published on the committee's website after this meeting. Members are reminded of the long-standing parliamentary practice to the effect that they should not comment on, criticise or make charges against a person outside of the Houses or an official, either by name or in such a way as to make him or her identifiable. Can I now ask Mr. Goodman to make your opening statement, please? Thank you.
I won't take long because my colleague Dymphna is going to do most of the speaking on the policy. So just to note a few introductory comments. So the National Oral Health Policy was approved by the Government in March of this year, so it's now the Government's policy in this area. The Chief Dental Officer, Dr. Dymphna Kavanagh, she led the development of the policy over a period and will set out for members the ethos, the principal features, the key plans and the actions contained in the policy. The policy is quite wide-ranging, takes an intersectoral approach as well as being consistent with the primary care philosophy of prevention, treatment at the lowest level of complexity and recourse to specialist care where this is clinically appropriate. This work is the culmination of a comprehensive programme of research, analysis and consultation over a number of years, and over time we'll be updating models of care and service delivery that have been with us probably for 25 years or more. The policy is aligned not only with international models of good practice, but also with the ideals and approach in other health policies such as Launcher Care, for example, and Healthy Ireland, obviously. Important to say, I think it doesn't seek to change all aspects of service delivery overnight, but puts in place the framework for real and substantive change on a phased basis. As with any area of public service provision, implementation will need to be planned and managed in consultation with all interested parties, and in particular the dental profession, and of course also those who use and depend on the services. And I'd like to just, I suppose, place on record, just for the benefit of the committee, that in the development of the policy and in the planning around implementation, the Department and the Minister are fully appreciative, I think, of the professional contribution that the dental profession makes, both in the salaried services with the HSE and so on, and also the contracted service providers who are in private practice, and of course in the specialist services as well. So I'll now hand over to Dr. Kavanagh.
Thank you very much.
Thank you, Fergal, and thank you, Chairman, for inviting me here today to outline the key aspects of Smile agus Launcher, which is the National Oral Health Policy, and it was launched in April this year by both the Ministers for Health and for Employment Affairs and Social Protection. It's a comprehensive, as Fergal said, an evidence-based policy. It's informed by extensive research and consultation. Its aim is to facilitate better oral health for everyone, and it will also support continued professional development for the profession. It's a transformative programme. It introduces and manages a series of changes over 8 years. The policy is aligned with other government policies, including Sláinte Care, Healthy Ireland, and the first 5 years, which is a whole of government strategy for babies, young children and families, as well as the national strategies on disability and mental health. It conforms to the international policies of the WHO and the European Union. The policy embraces the No Child is Left Behind principle in the first 5 years and the education policies. This is the very first major oral health policy statement in 25 years, and much has changed in Ireland in that period. The standard of general and oral health, materials and technology in dentistry, and the types of services we aim to provide. In developing the policy, we have ensured that it is supported by up-to-date information about the oral health of the population, as well as appropriate international evidence. A broad range of stakeholders were consulted, including those who use the services, as well as those providing the care. Our current oral health system is out of step with other Irish and international health services. There are gaps remaining in routine dental care for the very young and the vulnerable, including people in residential care, people with disabilities and older people. Smailog Sláinte reorients how care is provided in line with Sláinte Care, so that most dental care is provided in people's own communities as close as possible to where they live. This is beneficial for the service users and allows acute services to focus on more complex care. What is described in Smailog Sláinte is not a demand-led service. Instead, it enables the Irish public to access services, to forge a relationship with their chosen dental practice, and we call this their dental home. To support this universal primary care approach, a safety net system will identify those who do not or cannot attend their local dentist. This safety net system is part of the surveillance system outlined in the policy. Particularly for vulnerable children and adults, it ensures the most vulnerable, including those on lower incomes, will be supported and that they receive the same quality of service as the rest of the population. The existing public dental service will be stronger. A key service will be to identify, support, deliver care for vulnerable children and adults when it cannot be provided in local dental practice. The measures set out in this policy will also provide professional opportunities for staff in areas like health promotion, special care services, and in public health. There are key policy strategies and proposals, and I'll pick out a few of the key ones. You have them there in front of you. Water fluoridation, one of the key reasons why we have such good oral health in Ireland, will remain a cornerstone of oral health policy. Health promotion programmes, of course, will be put in place, both for the whole population, but also targeting the most vulnerable. Most children and eligible adults will be treated in local dental practices, and children from birth until 16 will, over time, in a phased way, replace the existing school programme. It's the first time that under sixes, teenagers and adults will have a lifetime access to preventive treatments such as fissure sealants and fluoride varnishes and access to dietary advice in dental practices. Expansion of primary care is proposed from birth until old age across the whole life course. We have focused on improving access for vulnerable groups, low income, rural dwellers, people with disabilities, and enabling them to get to local dental practices is key. As I mentioned already, the safety net service is essential to ensure that their needs are addressed and that they get comprehensive care. Let's not forget that we need advanced care services and specialist services as well, including, and that will include the concerns around dental general anaesthesia. Monitoring systems will have to be put in place, identifying people not taking up the services, overall dental needs and the policy's impact. There will have to be a full review of dental undergraduate education, and in tandem with that, we will also need career-long professional mentoring for dentists. I want to briefly talk about the development of the policy. As we mentioned, the policy was informed by oral healthcare professionals through a series of working groups and consultations. We are indebted to the Academic Reference Group, and we drew expertise from Irish universities in this regard. These experts assess current needs and how best to meet them. In addition, we also had an external international independent panel. These are international leaders in different aspects of policy development, And out of this, recommendations from the reference group and research was quality assured in line with international standards. All research undertaken, including the additional fact study analysis, was robust, representative, ethically compliant and externally quality assured. During policy development at the start in 2014 and again in 2016, letters inviting comments to the whole profession, all dental registrants, over 5,000, were sent from the Department of Health, inviting them to engage in policy. A stakeholder day was held with over 70 attendees from 16 representative organisations. There was one-to-one engagement with dental practitioners in independent practice and also with those in the public dental service. Their views overall highlighted an appetite for change in oral healthcare services, but emphasised the challenges of such a change. The Dental Council training bodies, including the RCSI, expert body on fluorides, were also consulted and given a draft document. These engagements informed the direction of policy in key aspects of service provision and training for professionals. I've outlined the key findings, both from the public aspect and also from the dentists as well. So from the public point of view, I'd just like to mention a few points. The first one is they indicated that the current system is complex and very difficult to navigate, and they were worried about cost, particularly in relation to children's care. Young children rarely attended before 6 years of age. Over 55, which was of concern to us, there was a decline in quality of life, which sharply declined into their later years beyond 70. Overall, all age groups and social classes perceived their main access to care is via their general dental practice. Stakeholders and practitioners insisted that very early childhood care is needed, but also wanted special care services for the vulnerable. They expressed frustration with bureaucracy, barriers in accessing care for patients, and an outdated state payment system. There's a greater need for emphasis on primary care in the profession to bring it forward. And the public dental service wanted to emphasise prevention and have opportunities to expand their skills. So this fundamentally changed a lot of the direction of our policy when we got this information from the consultations. Leadership roles in primary care to refocus the profession and facilitate leadership from within the profession is a key action coming from the dentists. The policy also included very early intervention for children to give them the best start, but the need for comprehensive support for the most vulnerable through specific support services within the reoriented PDS. With the policy action, career-long mentoring framework, like other professions such as social work and psychology, will be put in place. Undergraduate and graduate education is a priority, and indeed the first priority within the policy, with an emphasis on training in primary care. The policy also includes a review on dental technology and clinical dental technology training, and this was a key issue that arose both from the public needs in residential services and the need to maintain a sustainable workforce in this direction in relation to dentistry and in relation to dentures and prosthetics in relation to total tooth loss. I know you're going to be particularly interested in implementation, where all the action is. So you've been given an overview document which we have shared with you and showing 41 actions and the priority for each of them over the next 8 years. This implementation period is needed to commit actively to engagement on significant and complex issues. Firstly, we need to build a framework to support long-term sustainability, the education review, mentoring framework, focus on legislative issues, and the department has already begun to discuss the priorities with key agencies, and we are agreeing targets and timescales. I'll give you some examples. For example, in Action 29 in the policy, which is a priority, the National Plan for Amalgam Phase Down, we have worked closely with our colleagues in the Department of Climate Change, Communications, Climate Action and the Environment, and key stakeholders, and it is being finalised in line with Ireland's EU legislative obligations to publish on July the 1st, 2019 and submit to the EU in August. A full review of undergraduate training, which we've mentioned, graduate mentoring programmes and upskilling for graduate dentists are key immediate actions. Dental Council, through the support of the Irish Committee of Specialist Training in Dentistry, will lead in developing the Advanced Centres of Care framework, which is for the specialists. We are convening in July to commence this work. The first 5-year strategy, is working with the Department of Health to support the framework for the Under 6s policy in the programmes of health promotion and services. We've already met with the Clinical Dental Technicians Association and we have its support to assess dental technology training. Water fluoridation will remain. We continue to review that. And we're linking with the expert body on fluorides and health. The HSE have two main service focuses. Epidemiology data indicated that those in residential settings require urgent attention and support. The reorientated public dental service, the community oral health care services, will identify their needs and put in place a treatment programme for those who cannot use primary care. A second priority is on the very young group up to 6 years of age to receive packages of preventive and primary care. This is in line with Healthy Ireland, the first 5-year strategies, and also giving the opportunity for the public dental service to release capacity. Implementation of a transformative policy like Smile agus Sláinte will present challenges, all change is challenging. However, those challenges will also present opportunities for the staff in private practice and in the public dental service. It's important that implementation is owned by the profession, listening to the voice of the public. And to achieve these priorities, we need key leadership roles, both operationally and in dental schools. Primary care, special care, advanced or special care delivery and public health leaders must be in place so that implementation is sustainable and placed where it belongs in the services. I'd like to thank you, Chairman, for giving me the opportunity to outline the national policy. And we look forward to working with our colleagues in the HSE, professionals and key stakeholders to implement this change.
Thank you very much, Dr. Kavanagh. And now can I call on Professor Brian O'Connell from the Oral Health Policy Academic Reference Group.
Thank you, Chairman. My name is Brian O'Connell. I have been a practicing dentist for 35 years. I'm a consultant in dentistry and Dean of the Dental School in Trinity College. I'm accompanied here today by my colleagues, Dr. Jacinta McLaughlin, who's a specialist in dental public health, and Dr. Alison Dougal, a consultant who treats patients with serious illnesses and disabilities. We're here on behalf of the reference group, and our chairman, Professor Mullen, has submitted a letter that addresses, I think, a number of the specific points that were raised about the group's work. The reference group was established to help provide the Department of Health with the independent best evidence that could be used to improve oral health in Ireland. It's a broad group with a range of backgrounds and disciplines relevant to policy development. Like all dental professionals, and indeed the public, we are acutely aware of the shortcomings of current dental services in Ireland. There remains huge inequality in oral health, especially among the vulnerable groups and those even living in rural areas. We see parents of children with disabilities who are often desperate to access appropriate care. Far too many young children turning up at hospitals needing emergency extractions, and those who are frail, living with dementia or in residential care often find their oral health is completely neglected. And the training pathways that have been needed to sustain oral health services have not been developed and in some cases dismantled. But the other thing that you need to know is that most dental disease is preventable. Dental decay and gum disease, which are the main reasons for tooth loss, pain and infection, are two of the most common diseases worldwide. Yet preventing these diseases, and indeed oral cancer, is possible to a large degree with simple primary care measures. The reference group proposed principles that might frame an oral health policy, and you've seen some of these in the final Smile agus Sláinte document. There's the common risk factor approach that recognises some of the same factors are involved in oral and other diseases, so controlling those risk factors can have a big impact on health. For example, high sugar intake is the main cause of tooth decay, but it is also implicated in obesity and type 2 diabetes. Reducing sugar intake should therefore be the business of the whole primary care team, including dentists. Importantly, the provision of a service like dental treatment must be surrounded by broader public health policies to really make a difference. The life course approach means that individuals need access to different services throughout life and depending on their own circumstances. However, at all ages, our population should have a home in a dental practice setting that's focused on prevention and empowering them to maintain their oral health and independence. And as part of Sláinte care, oral health care must be available to all who need it, regardless of income, location and disability. These are just a few examples of policy recommendations that have been included in Smile Agus Sláinte, which will be crucial to really transform oral health in Ireland. The principles are not only well established in government policy, but also contained in recommendations from internationally recognised professional bodies. Those of us who want to provide appropriate care for patients know that an oral health policy itself will accomplish nothing without determined and sustained implementation. Continuing with current services will not improve the oral health of the population and will exacerbate inequalities. Available evidence is strongly supportive of change. It's vitally important to build confidence in the public and in dental professionals that we will be supported in our roles. Most of the population can be readily treated in a practice setting, and a strong primary care system reduces the need for more complex interventions. Nonetheless, primary care providers cannot be asked to take responsibility for patients unless they know there's access to backup and specialist care where needed, as outlined in the policy's Advanced Centres of Care. It's also essential that we monitor progress as we proceed to make sure we're achieving the goals of the policy for all people. The evaluation and research parts of the policy are critical to a successful outcome, as emphasised already in the Healthy Ireland framework. All of these issues have been recognised in Smile Agus Sláinte, and we welcome the publication of priority actions to be addressed in the coming years. Finally, we would like to highlight the need to develop a workforce that's fit to deliver the best oral health care across disciplines to the greatest number of people, as stated clearly in Sláinte Care and described in the oral health policy. Smile Agus Sláinte proposes a review of dental education and the development of primary care leadership across the dental schools, and I hope the HSE, to ensure that dentists will be central pillars of the primary healthcare team. This may include extending education in a mentored environment to encompass broad community experience, interprofessional teamwork and general practice skills. The oral health policy provides for ongoing access to retraining through a skills match programme, so the dental team can keep abreast of changes in the population, in disease patterns and in technology. In order to support patients and practitioners, specialist and academic training must be put back on a firmer footing within the established medical model. As the policy has stated, it's also time to look at the scope of practice of the whole dental team so that the population has the greatest possible access to good quality care. My colleagues and I have the privilege of working not only with students, but also the whole dental team at all stages of their careers. And I can assure you that in this country we have a talented and dedicated workforce whose skills are recognised everywhere. And I'm confident they're capable of meeting any challenge that they embrace. Thank you.
Thank you very much, Professor O'Connell. So we're now going to open the meeting to our members, and Deputy John Brazel is substituting for Stephen Donnelly. So, Deputy Brazel.
Thank you, Chair, and thank you for coming in and giving us your statements. You might just, maybe, because I didn't pick it up from your statement, as I understand dental service at the moment, the general public, the vast majority of the general public would be, their thoughts on it would be that you ring up your local dentist if you've got a problem and you attend and pay accordingly. The public dental system, who is that currently available to now? Is it medical card holders only, or is it the general public that most of them may not be aware that this service is there for use by them? And for the future strategy, is it a rollout of public services, or are you also including your dental practice in every town and some villages around the country? That's my first question, just to give me I didn't pick that up from your statement, exactly how the dental practices that are in existence at the moment will feed into your new strategy.
Okay, well, I'll answer first and I'll hand over to my colleagues in relation to that. So if I understand correctly, you're saying in the first instance, are the public aware of what the current public system entitlements are? That emerged from TILDA and in fact from the Irish study and the longitudinal study of ageing, and also when we did marketing research through Amora with the public. what emerged was that they didn't have an understanding of their entitlements or what was available to them, and perhaps the Tilda people might want to pick up on that because you... Sorry? So the current arrangement is in the public dental service is that second, fourth and sixth class ideally are seen, although in general it appears that second and sixth class are the main focus at the moment. So that's for children. And then there are emergency services provided beyond that. That's for the children's service. They also see some disability services as well. And then for the adult
and that's
service,
free of charge to all
that's
those?
free. Everybody under 16 years of age can access that service.
And then if a sixth class student, they determine that an extraction or filling is needed, is that then provided free of charge?
If they're in sixth class, and if it's an emergency system then outside of those key classes, then it's an emergency system, but they don't get additional primary care. They don't get a full check-up in primary, you don't get added on primary care.
Okay.
And for the adult service?
Yeah.
Yeah, so for the adult service, there's two separate schemes. There's the dental treatment services scheme, which is for medical card holders, and then there's the dental treatment benefit scheme, which is from the social welfare, from the Department of Employment and Social Protection. And so between them, they have so there are two separate schemes. One is health and one is from the social welfare side.
Okay. And if you're outside of that, then you go to your
Yes, we would
practice.
estimate that there's probably about 10% that would be taking up purely private care. But on top of that, people would, there's a big mixture between public and private care. People don't rely just on public care. As you know, you may be aware of, the vast majority of care is coming out of the public's pocket at the moment.
And for your new Smile Agus Slánta, what's the...
Yes, so the first step is that it's part of the Sláinte care, which is moving towards universal care ultimately. So we're taking the first step by focusing on people who are currently eligible. But that's why it was launched between both welfare and health, is that we're working together so that we can have the same services that would run a line together, so that medical card holders and those that would be in the welfare side, the intention is that we working closely together so that we bring the two populations together in providing services, and that would be a huge majority of the population. And then ultimately, we're all ambitious that as Sláinte care would be rolled out, that this would be perhaps the first steps towards universal care, but
Okay.
not immediate.
My just thoughts on it would be the capacity. Sorry. Yeah.
Yeah, just a supplementary point, I suppose, to pick up on the last point that Dr. Kavanagh made, is one of the tasks in Sláinte care is a very substantial piece of work, I suppose, which is to review the health services whole system of eligibility for services and payment structures and all the rest of it. So there are quite a lot of schemes in being at the moment, and we have the mixed public-private system to which you allude in not just in dental care, but in other practice, other services in the community, and obviously in the hospital system as well. We have a variety of arrangements. So that is one of the kind of core objectives of Sláinte care, is to take a stand back from that, do the analysis, and come up with sustainable options for consideration. So that's a sizable job of work, and I suppose that will inform eventually what will happen in oral health service as well, because they'll have to be included in that consideration.
Okay. Just in your statement as well, you outlined that when you were developing the policy that you wrote to 5,000 dental registrants. Did you get much feedback?
Yes, we did. In fact, it was considerably successful. In fact, to the second letter alone, we got 256 responses to it. In the first, we also got a lot of responses back from professional organisations as well, such as the Periodontal Society, the Irish Society for Disability and Health, and the Irish Dental Hygienists. So many of the professional organisations also responded to us. But yes, 256 general practitioners responded to it.
And the Irish Dental Association?
The Irish Dental Association were specifically written to and asked to submit their responses, and they came back to us in writing and declined to submit their responses. But we had briefings and engagements with them, as we've outlined. So we met them both specifically on the policy. We'd meet them on other issues, but specifically on the policy, we met them in 2018 and 2019. We gave them a full comprehensive briefing of the policy, an overview of all the ethos. I don't think there was anything left out from our records, and then we met them again in 2019 as well, before the policy was launched. And I would have had one-to-one engagement with the ex-president as well to discuss issues.
Well, for your information, you're probably well aware of this, but the Irish Dental Association would claim that that they weren't properly consulted, and that they claim that the new policy will make dental health worse instead of better. So there is an element of, I suppose, clarification or relationship building needed there, because that's what's been fed back through the political system, that they weren't overly impressed with the consultation system through this process. I don't know if you're aware of that or not, but that's certainly that's what's going back to us as politicians, that they believe that they weren't properly consulted. So that, whether that is factual or not, I don't know, but it's certainly out there in the ether. The other issue that I want to just finish up on is my colleague, Deputy Stephen Donnelly, would have put down some parliamentary questions around waiting lists, and the responses are quite complex, but if I just go to the last page, those waiting less than 2 years on a treatment waiting list is just over 10,000. Waiting 2 to 4 years is 7,113, and waiting greater than 4 years is 1,316. So you're looking at a total of waiting of 18,400, which I think is a substantial amount of people. Is there a...
I would hand that to my colleagues in the HSE to answer that question.
Yeah, is there just to tackle that particular backlog, because it is a considerable figure, particularly, people waiting between 2 and 4 years of over 7,000, I think is very concerning.
Deputy, in coming to the committee, we submitted a report here which has those figures and sets out the services that we provide, and include, in relation to orthodontics, the waiting list. So we're currently treating just under 18,000 people, and there are 18,000 on the waiting list, as you say. There are currently working with us on a whole-time equivalent basis 13 consultant orthodontists, 45 orthodontic specialists and 64 dental nurses in our regional orthodontic services, and we fully acknowledge that those who are being treated currently are the most severe and the highest risk, and that's the way that we are dealing with them. And I'll ask Dr. Joe Green just to comment on what arrangements we have and try to prioritise that.
Okay, thank you for your question. In response to the long waiters in particular, in 2016 the HSE initiated a procurement process, and at the moment there are 1,489 patients being treated through that. We're hoping to extend that later this year or early next year, if funding permits.
So, sorry, is that putting it out into the public?
With specialists in private practice.
Similar to National Treatment Purchase Fund? Okay.
Parallel to that.
Okay.
The other options, assuming that the criteria are retained, there is a threshold. As Mr. Healy said, the HSE provides orthodontic treatment for the most severe and complex cases, and there's an assessment system in place through which that decision is made in relation to each child who's referred from the dental service. The initiatives that we're looking at would be to increase capacity of the regional orthodontic departments through an expansion of the number of specialists, but also with the possible introduction of the grade of orthodontic therapists into the HSE. These are important members of the dental team who work directly with specialist and consultant orthodontists, and it would allow us to increase the capacity of the service quite quickly. So we're in discussions around that at the moment. We'll be hoping to introduce that grade into the regional orthodontic service in the course of the next year. But
I mean,
there's work to be done there.
would you have, given that you've approximately 18,000 waiting, do you have like a target to bring that down to 10 in next year? And do you have a kind of maybe a 3, 4, 5 year plan to say we want to reduce this to?
In the context of last year's estimates, we had the plan to go to 3 years, and that would take about 18 months to 2 years.
Okay.
And then incrementally to go further. But if we can make progress with the introduction of the grade of the orthodontic therapist, I think that would help substantially.
Okay. And I would just, as a suggestion, say that the use of the national treatment person, it would be, it's a service that's there and it's available, and
we're looking at all those options.
Yeah. Okay. Yeah. And just lastly, just as a politician carrying out weekly clinics and whatnot all over the county of Kerry, I would, not every week, but certainly monthly, get constituents who come in with their younger children. And apart from the issue of dental health and concern, there is a significant sort of psychological attachment for young people, image conscious, that area. So it's more than just your healthy teeth, it's your well-being as well. And I think that should be, I'm sure it is, but needs to be taken into consideration that when a young person is growing up, they're very, very conscious now, far more than in the past, and that needs to be taken into consideration when assessing the urgency of a particular case.
Through the chair. Yes, through the chair. Thank you. I just wanted to go back to clarify that point in relation to the Irish Dental Association. In fact, we held a stakeholder day, and it was, as I mentioned earlier on, it involved 22 representative organisations were invited and 16 attended. The Irish Dental Association themselves sent their own representatives, 3 to 4 representatives, and indeed they led on the roundtable discussions themselves in that regard. In addition, they, as I said, I outlined the briefings that we gave them, and my understanding is that they talk about it being meaningful consultation. I hope I have outlined how much attention we paid to that consultation and how much we took on board in relation to the policy as well. I don't know if any of my colleagues want to pick up on any of those points in relation to consultation. We also, I should have mentioned as well, that we went out, we had a year-long structured engagement for dentists and salaried services that was carried on, and very intensive structured interviews, and was analysed with the University of Sheffield. And many of those that participated were in fact Irish Dental Association members. Perhaps Brian or Jacinta?
Oh, sorry. Okay. Yes, and in addition to what Dr. Kavanagh said, the Dental Association, and indeed a lot of other associations, also over the years have produced a lot of their own documentation and their own policy suggestions and recommendations, and we looked at all of those as well. And in fact, I think you would find a huge amount of crossover between the consistent recommendations of bodies like the IDA and what is in the policy. Ultimately, and these things are not really that controversial. I think, that children, for example, should be seen much earlier, and so problems are prevented before that they wind up in hospital and wind up with acute emergencies. This is all in policy and in recommendations that IDA and every other professional organisation has put out there.
So, from your answers, then I'm taking it that you're of the belief that there's buy-in from all the bodies, including the IDA, into the new policy.
Well, I obviously can't speak for them. What I would say is that in terms of the policy itself, I think there is huge amounts of agreement over most, if not almost all of the areas. I think that the things that people have said to me, and I speak to dentists every day, and the concerns that they've raised have been largely about the implementation of the policy rather than the policy itself. And, you know, will there be enough funding for it? Will it all be implemented and so on? And, you know, I certainly can understand that, and those of us who work in the system can understand that. You know, we don't have always a great track record of funding everything properly and making sure all parts of it are working. So I certainly can understand why dentists would be you know, anxious about the implementation of the policy, because in the end of the day they want to deliver a service for the population like any health profession, but they want to be able to do it in a way that's safe and that's sustainable, so that if they start to take care for a new group of patients like children or people with disabilities, that they're going to have the backup. That it's, you know, it's Friday afternoon at 4:30 and somebody appears in your surgery with a problem, that there's somebody that you can call, that there's somebody who will be able to see that patient if it's an emergency. So those are the kinds of concerns mainly that I think underpin a lot of what I've been hearing.
Thank you.
Yeah. I'm a special care dentist. Started off working in general practice, then moved to the equivalent of the public dental service, developing a special interest with people with disabilities, then undertook considerable training to become, I'm now providing care for people with very complex disabilities. As well as perusing the evidence, we consulted very heavily with professionals working in this field, but also with people with disabilities themselves, with our medical colleagues. And I draw your attention to an excellent document back from 2005, which took together the viewpoints of people working in this field, people from the HSE, the National Disability Authority, who all were in agreement that the key to managing the very real problem for people with disabilities was mainstreaming their oral health. There was very big agreement on that. Currently, the available of appropriate care is ad hoc, and people with disabilities are grossly underserved, and they experience high levels of unmet need, along with reduced treatment options when they even are able to access care, and their outcomes are poorer. A recent study from IDS Tilda showed us that people with intellectual disabilities who are now living into older age are twice as likely to have lost all their teeth, but more importantly, are 12 times more likely not to have been offered or are not wearing dentures, let alone bridges or crowns to replace that, to ensure their dignity, and importantly, to allow them to chew a healthy diet. The inequality, there's agreement amongst the profession, this is unjust, unfair, and importantly, really unnecessary. We know that most people from these vulnerable groups have needs which can be met with very small adjustments, reasonable adjustments in primary care. And we must be very mindful, and this was something that came up in consultation, that when the public service fails to meet these people's needs, because they're already impacted by social inequality, they've had less access to education or well-paid jobs, their ability to pay for alternatives is hugely reduced. So we know from the literature that only about 8 to 10% of people with disabilities require specialist care. But where that care is required, it needs to be produced by very high-trained people with access to adjuncts such as general anaesthesia, sedation, but also are very well advised with consent and ethics and working with the teams and in social care. I think it's very clear that availability of care in mainstream services is what people with disabilities want. It's what they've asked for, and there are great models to actually showcase this working very well. However, what is urgently required for people with disabilities, long-term conditions and frail older people is well-posted, is well-signposted pathways to services in a timely fashion, because for a lot of these people the only way they can receive basic care is with general anaesthesia, sedation or experts. So I believe that the oral health policy and the consultation that we've gone through think that this policy provides the structure and the opportunity to address the frank inequalities that we're seeing, right from early intervention in childhood, right through to frail older age. But I think for the first time, targeted preventive packages in primary care and establishment of these community-based services is really important. Evidence has shown us that educating the general dental workforce and exposing them to diversity in their training gives them the skills and the knowledge to manage most people with disabilities. And I think the training of the workforce, supported by specialists, is really important. We cannot expect our primary care providers to accept people with complexities into their workforce if there isn't a very well-structured framework and pathways to support them for those few patients for whom it's beyond their scope.
Thank you very much. Alison. We're now going to move on to Deputy Louise O'Reilly. Thank you.
Thank you, Chair, and I apologise for being late. I was showing some solidarity with workers this morning on the picket line and I got caught in traffic, so my apologies. But I have had a chance to read over the submissions. This thing about the Dental Association, I can't get, because we had the Dental Association here and they were very, very clear. Their considered view is that they were not consulted with, that there was no meaningful consultation, that they don't see their views and their position reflected back in any of the documentation. And I'm just struggling to understand how it is that we can have two people in on two separate sessions who can have two so completely divergent views of the same process, because I mean what you're calling detailed consultation, they're certainly not of that view, and I suppose there appears to have been some meetings, but what they're saying is they just can't see their views, and they are the body that represents the profession, but they just can't see their views reflected in the policy as was announced. And we maybe will never get to the bottom of it, but I suppose it's just worth observing that they were very strong in their view that they hadn't that there hadn't been any meaningful engagement, and that they hadn't been their voices hadn't been heard, and certainly not reflected back in the policy when it was launched. And I think that's whether or not, and we could detail all the meetings, and we could have 100 meetings in here, and if I didn't listen, or if you didn't speak, or do you know what I mean? Like the fact is that is a difficulty, and something which I hope in terms of rebuilding the partnership and all that work can be done on that, because their view very clearly contradicts the one that you have given us here today, and I don't know that we'll ever square that circle. But I mean, without a time machine, you certainly can't fix it. But going forward, it would be important that that relationship would be re-established. Or I mean, maybe I'm not asking you to accept that it's broken down either. I'm not trying to put words in anyone's mouth. But for us, it's very difficult, because we have now heard two completely divergent views of what is essentially the same process. So I mean, I'm not sure that there's much more can be said on it, but it is curious, certainly to me, to try to understand how we can have two sets of professionals engaged in some form of dialogue, and the end result of which is one group very firmly feel they weren't consulted, and the other group very firmly say that they were. And I think that is going to pose difficulties if that situation is not somehow rectified. Okay, that's on that. But it's not mentioned in the submissions. I don't think. If it is, I missed it. And I know that there was some media reports in relation to an audit of orthodontic services that was carried out in 2015 and calls for that to be published. Is there any? I know that I think what I read at the time was that the position of the HSE in the department was that this was just a scoping exercise and that there would be any need to publish it. But I'm wondering now if maybe you can just explain to me why that hasn't been published, or if you could.
So, Deputy, I checked before coming this morning just with my colleague, the head of operations on the community side, whose area this is in, and I'm advised that, just as you say, like that the report or the scoping exercise was one part of a process which has advised the HSE on the actions it should take in determining the range of risk, or if there was harm or whatever in relation to particular cases. That has led to an audit and a particular clinical review which is currently underway and nearing completion. And so when that's completed, there will be a serious incident management team then will look at the output of that process and determine what the next best course of action is in relation to it. So publication or that, I think, it's not it's a scoping exercise that was done. What's important is that the clinical review that's underway and the audit that's underway, that the work out of that, which is nearing completion, that's actioned, and any action that needs to be done would be followed up. And my colleague, Dr. Green, can provide any other detail that you might need.
Well, I suppose the detail is fairly simple, Pat. It's just a copy of the original exercise that was done in 2015. It wouldn't seem to me outrageous that would be published. I mean, we've just been through, say, take the Scally inquiry. That was a scoping inquiry. The terms of reference were very public. The scoping inquiry itself was very public. The recommendations were very public. They were shared with the people affected first. Well, not in all cases, but we won't dwell on that. The intention was to share it with the affected people first and to put it into the public domain. You'll understand there's a wee bit of concern, obviously, because it appears to be there's a bit of secrecy surrounding it, which I think is causing people to be to maybe wonder what it is that's in it. If it's only a scope, and the attitude seems to be a bit sort of, I will look at it, there's not much in it, but if there's not much in it, would you not just publish it?
What I might do is just, obviously today was focusing on the policy and so on, so what I'll do is, there's certainly no question of secrecy or whatever, and I know that this was, I think it was on media coverage, as you said, so I certainly arrange for for a formal note to be sent to the committee just outlining people who are exactly
that's
where
great.
the position is.
Thanks, Amelia, but that's excellent.
Right, just before you leave that point, this refers to an issue in relation to the Mid-Leinster area where orthodontic services were discontinued, and there was a sense that some children had suffered because of the discontinuation of that orthodontic service. And the Health Committee in previous governments, I think in 2005, held meetings in relation to this. And then two experts from the UK came to look at the evidence, and those two experts have called for their review to be published. They completed their review in 2015, and that review has not been published. So I think that's the issue, because I and many other deputies in the Dáil have been approached about this, and we have all asked parliamentary questions. Yeah. And the answer we get is that the review is ongoing, but the review that those two specialists from the UK completed in 2015 has not been published.
I think the thing to do is I'll get a formal response to the committee just to clarify the exact position on that, as it's being operationally managed within the system. And
the intention, sorry Chair, the intention is not to ambush you with it, Pat, be assured of that, but please hear this now. If the detailed note is just going to be a rehash of the PQ responses that we've had, I can just tell, I'm not speaking for anybody else, but I don't think anyone will disagree with me. I can tell you in advance it's not going to be good enough. So, I mean, I suppose we're all wondering why the information that's there can't be shared.
I'll certainly establish that, and I'll arrange for a response to be provided to the committee.
Thank you, Chair.
Mr. Goodman, sorry.
back in on the point about the Irish Dental Association, and I think Deputy has probably reasonably kind of summarised that you can have a situation where different parties are involved in a process and at the end of it still have different perspectives, and maybe we will have to agree that that is as it is. But what I would say is that as we move into implementation of the policy, it undoubtedly will require a high level of engagement with both the IDA in their representative role of, let's say, external providers and as the union for salaried staff in the HSE. Mr. Healy and I, as you're probably aware, Chairman, were involved in the process in recent months in respect of medical general practitioners, and I suppose despite a lot of toing and froing and tension and difference of perspectives, in the end of it we come out with an agreement. And I think going into reform of dental services, that is really what we will be aiming to do as well. Pat might want to amplify that a bit. He's been involved in many significant change programmes in the HSE.
And I just agreeing with what Fergal Goodman is saying. I think the important thing, and a number of deputies have mentioned it so far, of course there are concerns that have been identified by the IDA. I think as we progress towards implementation, we're very clear that collectively ourselves in the department will have to be engaged in a very comprehensive consultation process with all the stakeholders involved in that, whether it is providers, our own staff, patients groups as well, and other interests. So you can be assured that there will be a comprehensive process of engagement, and I think if there are bridges to be built, I think we will try and use that process to arrive at a shared understanding of where we need to go and address the concerns that have been identified. And I think it's important to say as well, I read carefully the IDA's submission, and while they did identify a range of concerns, they also identified positive areas, and identified 4 or 5 where I think there's common ground. So I think there are areas where we can build and address the concerns as we go.
Okay, so Chair, I have a number of fairly specific questions, if that's all right, yeah. So the first one concerns the existing number of, and look, I just put my cards on the table. This policy and this announcement, to me, it does sound like privatisation and further privatisation of a service which is contrary to actually what's in Sláintecare, because Sláintecare places a very heavy emphasis on public provision. But that's I'd say that's the perspective I'm coming from. With regard to the number of HSE dental clinics that are currently in existence, how many of those are in existence at the moment, and under the new model, how many will be closed, or will their work be changed, or will they still be open but doing different work? What are the HSE clinics going to look like? I suppose the first question first is how many of them is there, and what's going to happen to them?
Yeah, so I get Dr. Joe Green just to comment on the detail, just to say, like, we set out in the report that we provided just the detail of all of the services. It references the clinics as well, and the staff. I mean, there's a significant number of staff currently working in the service. There's something in the order of 657 WTs. Yeah. I'll ask Dr. Green to cover the detail of that, but just to say that it's really important that we would emphasise that while the policy identifies a roadmap for the future, there's a real recognition of the good quality service that's currently provided by the HSE. At the same time, it's targeted and it provides to a priority. We prioritise need towards a targeted group, and the issue of access is one that has to be addressed, and I think the policy is seeking to do that. It does reorientate the role of the HSE service, particularly focusing on special care in terms of special needs, ageing populations, vulnerable groups and so on. So that's part of the implementation process that we'll be involved in. We'll have to work that out.
Sorry, just on that, Pat, sorry, Mr. Healy, but as you say that the HSE is doing such a good job, would it not make more sense to expand what the HSE is doing? I mean, the issue around access, nobody has a difficulty with the quality of dental care provided within the HSE. The issue of access is the one. Yeah. So, I mean, to my simple mind, expanding what the HSE are doing would actually improve access to what you say yourself is a really good service.
I think when I look at the policy, one of the things that it does is it looks at what's happening internationally. What are they doing? We're relatively good in what we do within the limitations and the resource we have and so on. But if you look at other countries that are well developed and good at this, they're all moving in a different direction. I think the policy builds on that and sets out a roadmap. Will there be challenges in that? Of course there will, and that's why we will have a comprehensive implementation process to work through those. It is important that we reassure our own staff who are working in the service that there'll be full engagement and consultation with them, and I think the policy provides for that. But I'll ask Dr. Green to just cover the detail of where our existing clinics are.
Thanks.
The direct answer to your question is 221 dental clinics, Deputy. Thank you for your comments on the quality of service that's provided. I think our staff do a great job.
Fantastic
in
job, yeah.
difficult circumstances. As you know, they deal with children under 16 years of age and special care children and adults. Sadly, it's for some children, for many children, the first interaction with the dentist is a consequence of having pain. And we would like to see children, or have children seen at a much earlier age. If they do have pain, they attend our clinics, and they're dealt with by very highly skilled staff, well-motivated staff, and they do a very good job, as I said, in difficult circumstances. Many people's first experience of dentistry is quite a difficult one. As I said, it might come as a result of pain or trauma, and possibly loss of sleep. Might be onset of infection, and no one's maybe in the best of form when they turn up at a dentist if they've had symptoms. So the staff that deal with that on a daily basis, and since we started this meeting, probably about 300 children have walked into dental clinics and private dentists around the country with pain. About 70,000 a year attendances for emergencies in the HSE service. So that's quite a large quantum of service, and we're very proud of the efforts that our staff make to look after children. As I said, clinical dentistry is something that not many of us look forward to having. Not many of us look forward to having treatment. And clinical dentistry in young children requires highly skilled staff and well-motivated staff, and it requires high standards of care as well, and that's what we strive to provide. The same group of staff also provide services for children and adults who require special care, and they also provide services in many of the hospitals, provide treatment under general anaesthetic for children and adults as well.
Okay, but my question was in relation to 221 clinics, so we're on full implementation of the new policy direction. Will they be closed? Will they change what they do? Will they keep doing what they're doing at the moment? Will the 657 WTEs, as Mr Healy's outlined there, they will still be employed, presumably? Are you planning on expanding the number of workers? Are you going to keep it at 657? Are you planning on phasing them out?
Okay. First of all, I'm not planning phasing out anyone. Our intentions, the HSE, with regard to the implementation, obviously the policy has just been published recently, and therefore we'll have to work with the Department of Health and other stakeholders to deliver an implementation plan. The future role of the HSE dental clinics will depend on the profile of services to be developed. I'd envisage that the existing staff will undergo quite a bit of upskilling in order to provide a greater level of service for people with disabilities who require special care. That will involve investment both in skills and in facilities. To return to the number, I can't give you a number of clinics that will be in existence in 5 to 10 years, because they change from time to time in order to develop better facilities. But what I can say is that we'll be investing in the staff, and we will also, there's quite a lengthy transition period under the plan, so we will be providing our existing service at all times with the priorities of care that are in place at the moment. Every child will be, if a parent contacts a clinic with a child in pain, they'll be offered an appointment same day or following day. And we aim to keep that service in place at all times.
Can I ask, did you look at any other models? Because I said to you, like, I regard this move as a privatisation of the service, further privatisation of the service. So just in relation to the cost-benefit analysis, and Mr Healy and I would have had conversations previously in relation to the home help service, and without meaning to put too fine a point on it, I suppose I was right. It was, much of it was privatised, and at the time I was told, no, this will just enhance the service, and of course it didn't. But I'm just wondering, was there a cost-benefit analysis done in terms of the investment in the public service, building up from 2 to 1 clinics, increasing the staffing, delivering more through the public service versus purchasing in from the private sector? And just by way of an example, what we saw happen with the home help hours, so directly employed home helps would provide the service for approximately 13 to 16 euros an hour. Once you start heading towards the private sector, you're knocking on the door of 44 euros an hour, and you lose control, you descale, you lose that out of the public service, and it's to my mind, it is not a good thing that would be lost. But I'm just wondering, in terms of the homework that was done on it, what sort of cost-benefit analysis was done? And I appreciate you say that in other jurisdictions, they looked at this and this, and they may be travelling in another direction. But as my mother used to say, if all your friends stuck their finger in the fire, would you do it as well? It doesn't make it necessarily right.
That's a question. That's a policy development question. It's really for the Department of Health, Chair.
Yes. Senator McLaughlin.
Just thank you, Deputy, for your question. Just to explain, my background is that I worked in what was then the Health Board Dental Services for 21 years, 7 of which I was a principal dental surgeon in County Meath. So I can understand why you asked that question, and obviously concern for the staff that are there. I was a principal dental surgeon when the last policy was launched and being implemented, and part of that was the department very kindly offered us more positions, more dentist posts, and it also coincided with the introduction of dental hygienists. We had great difficulty in County Meath filling those positions. I actually went to Stockholm to recruit dentists and managed to recruit a few to fill some of those posts. The problem being that as it's currently set up, the dental service, the Public Health Board or HSE dental service, is not very attractive, particularly to new graduate dentists. So people you'd like to get in would be the young and enthusiastic, because of unlike in medicine, dentists graduate with a very wide range of clinical skills. In Dublin, they start treating patients, doing irreversible procedures in patients in year 2 of a 5-year programme. So they come out with a very accomplished range of skills. And if you go and work in the salary dental service, it doesn't allow you to use those skills. Now, in the past, there were more opportunities to use them. Certainly when I was in the health boards, there were opportunities to treat adults. And, for example, I worked did some of that kind of treatment and worked in psychiatric hospital and all that kind of thing. So the point being that if you just having extra positions really doesn't necessarily solve the problem if the posts aren't attractive. And of course, as you would be very well aware of, salary cuts and changes in the pension arrangements and all these things impact on the attractiveness. So the model of care needs to change, and has been said and is clearly outlined in the policy, and Dr. Green has said it as well. There will be a lot of support for that, because people do understand the need. If you're going to reorient the service, you have to give people the skills to deliver it. I think, the reality is just offering extra posts is not going to work in the current model, and that's what the policy proposes, is to change the model.
But my question was about a cost-benefit analysis and, how that was done.
Yeah, okay.
Thanks.
I'd like to answer that question. In fact, we absolutely had to address that issue, and in fact it took 4 separate phases that were undertaken to look at it. In the first, it was commissioned out into University College Cork, indeed by the reference group, to look at the cost-benefit analysis of the various services. And out of that, and also there was a lot of international research in relation to salaried services. We looked at the Scandinavian models. We're moving away from their salaried services models and introducing in different types of models, not privatisation, but looking at public contracts out in the local communities. And what they found was that salaried services were best suited to providing services to vulnerable and special care services. For healthy primary care, it was not as effective and it was not as efficient in that regard. And there are multiple international studies in that regard. Also particularly looked at those countries that were similar. There's all different theoretical constructs of it, but the Netherlands, the Dutch model and the Icelandic model are more similar culturally and where we are sitting, and so we looked very closely at those models. The second stream then looked at all of the insurance models internationally and looked at what was successful and otherwise, but didn't just look at the oral health outcome of those models. That was obviously a key part, but oral health is influenced by many other issues of social determinants of disease and water fluoridation, not just by the service. But it also looked at the uptake, the buy-in culturally from the countries involved. And so insurance models are a model that works very well in Ireland, and we saw extremely good and fast outcomes coming out from many of those models. Then the final phase that we looked at after those two health economics phases, then we went on to the ESRI, and then they started to look and started to model various types of models, looking at mixed payment models. So we're not dependent on just one model. We're looking at a preventive package type of system of bundling, without going into the technicalities of it, for preventive packages, overlaid by a different fee per item system, and then further overlaid by service level agreements. The reason why we went down that model was because it was familiar to the public. They understood the insurance model. We had a lot of public consultation. They understood the insurance model more than any other model, and the outcomes from an insurance model are very, very good in a very short period of time, particularly for preventive orientated scheme, but also for the type of oral health that we're experiencing now, where the vast majority of children from good income to high income families have good oral health, but then there is this smaller group of vulnerable persons. We looked at the Medicaid model as well in America, whereby they increased access through practices, and what they found was, ironically, not that inequalities got worse, but that inequalities were much better for the very high risk and low income groups when they got in very, very early. And in fact, the higher income groups didn't tend to use it as much, but it really benefited the lower income groups. So there was 4 separate stages, because it's a huge change for us to undertake. So we had to look at the economics, and DPAR certainly put us through our paces in that regard.
I'd say they did.
And so for that, no, it wasn't a decision taken in any way lightly that we would look at a change of model. And as the HSE and our colleagues have rightly outlined, it would be in a phase stage, so that we would start at those services to release capacity in line with Sláinte care, to release capacity so that less services are provided in a secondary care service. And so as the younger and the teenagers would be taken up in local practices, this would release capacity as well within the HSE. There is no question of the HSE. The only intention is that the salaried service would be stronger, and as was pointed out by Dr. McLaughlin, that they would have an opportunity to use a broad range of their skills. And we've had a huge amount of support coming into us from the disability organisations, and they're employed by the HSE in that regard.
A specific model too. I provide care currently for a population with bleeding disorders, with haemophilia, and 10 years ago they would all travel to Dublin for all of their dental care. This led to waiting lists, it led to decreased access, it led to people who had difficulty travelling, needing to come from Mayo, from Roscommon. Over a period of 4 years, both by training primary care practitioners and offering what's called shared care, where people can receive their preventive, minimally invasive care near their home regularly. showed a saving of £2.5 million for factor usage for dentistry in a 2-year period. Now, economics is not the driver. What this also showed was really increased access to care and less invasive surgery, because the price of having to provide complex care in a secondary stage, whether it's GA, whether it's an integrated medical model in a tertiary or secondary care, is huge. So the ability to prevent by working with networks of well-supported, well-trained primary care professionals in the HSE clinics or in general practice, as the patient prefers, because patients have to have choice. And, and I think the greatest thing about this policy is giving choice to people into where they take their preventive packages, because that's been a big factor with patients. They want choice. They want to be able to attend the same practitioner, if possible, as their families, for example, not medicalising them. So I think choice, but also economics is a really big factor, and we can show that in many models with medically complex patients, for example.
And is it possible just to see in terms of the cost-benefit analysis? Yeah. Is that published? Can it be published?
It's developed by academics in University College Cork. I don't know if they have an intention to publish it themselves academically.
Okay.
But certainly we shared it with Deeper when we went into them, and I can certainly ask the academics.
Yeah. Okay. So the model that's proposed, there will have to be an increase in administrative work to administer that model, I would have assumed. Given that it's you're into service level agreements and fee per item, and that would there be? I'm asking. My assumption is there would be an increase in the administrative workload.
Well, in fact, it's the other way around, because on a packaging system, when you put it out for preventive, it's all just in one single menu. So it isn't about picking and choosing and then looking for each item. And that's the beauty of it from an insurer. That's why we follow the insurance models. They don't do it unless it's very easy administratively for them. So the packaging model is very simple and straightforward. It's just one package, one deal. Then for your routine care on fee per item, we're trying to put as much into the package as we could, but obviously routine, some of the care should be just picked and selected between the dentist and the patient themselves, but we're trying to lessen that. And then on top of that, for very complex care, which we want to bring more into practice, as was highlighted in line with Sláinte Care, then we would be looking at different models. It may remain fee per item, or it may remain service level agreements. So for instance, the use of implants for retaining dentures in the old elderly, there would be a lot of the majority of other public services would use that. We don't use that, and then we would have to see where our clinical dental technicians would come in, where our dental technologists would come in, and then we would look at contracts in that regard. So no, it's more simple for the patient. They don't have to worry because they have their package, and within that package it's simply a menu selection that they select from, and then the dentist can just simply send in a package regardless of what they pick from the menu.
Okay. Chair, I have other questions, but I'm conscious that there are other people who may want to come in, so if will there be a second round?
Yes,
an opportunity. That's fine. Okay, thank you.
Thank you, Deputy O'Reilly. Now, Deputy Durkan.
Thank you, Mr. Chairman. I welcome our guests. Thank them for their responses. Just a few questions arise. In relation to water fluoridation, how would you rate that in terms of being fundamental to good health and dental hygiene and general health as support? And how do you counter the lobbyists who are opposed by way of specific response as and when required? Question 3. How do you target, or do you target, specific groups, for instance, in the workplace, people who are at work for most of the day and don't have an opportunity of being available during the working day of the practitioners? So, and generally what happens then is they neglect to do so. We all do it until it becomes a serious matter. And we all do it then as well, when it may well be too late. But my question there is this: have you found a particular way or means or avenue to contact people, maybe in the workplace or by some other means, in the sporting areas? And well, obviously there are continuous contacts in the sporting areas due to injuries, but apart from the injuries, how do you make contact with that cohort of people of a particular age group who may have particular issues? Next question is, in terms of oral health, have you devised a system, or can you devise a system, whereby you can catch the cases that are most serious or likely to become most serious at an earlier stage? Question stands. And the Dentists Association, and I don't wish to go over again the issues that have already been raised, but do you feel it might be necessary for you to interact with the Dental Association to a somewhat greater extent, or for the Dental Association to interact with yourselves to a greater extent, and whether or not an established structure might be put in place whereby there would not be a situation where they were progressing on a particular route on the one hand and yourselves on a parallel route but a different one. How can you see yourselves addressing that sort of crossover that I believe might be necessary? Can you be certain that at this stage, right across all the socio-economic groups, can you be certain, or if not, how do you address it, that you have access to all those who are most likely to be in need of assistance, and whereby dental hygiene or oral hygiene is of particular importance? And I will take the answers along with this one as well, as in relation to women of childbearing age, the extent to which they have ready access and contact with the dental services, with yourselves, in order to monitor the progress of the value and quality of the support that they receive, and how their particular health situations in and out of pregnancies may be affected by a lack of adequate attention. And I'll take those for starters. There's 5 or 6 or 7 days. Should keep everybody occupied for a couple of minutes.
Well, let me start by water fluoridation, and again I'll probably have to link in with some of my colleagues. But from the policy perspective, as we stated, water fluoridation would remain a cornerstone of the policy, and the reasons why are it's the single most influential change of the improvement in our oral health, and that's been monitored since it was introduced in the 1960s. Much more recently, there was a Health Research Board study commissioned, which is known as the Fluoride and Caring for Children's Teeth, which was set up expressly to look at the impact. Is it still as impactful as it was before? And indeed, the outcomes are that it is. It still remains, there's a distinct difference between children who receive fluoridated water and those who don't in both their severity and the distribution of their disease. In addition, the department itself then also commissioned a separate study directly to the Health Research Board to look at the benefits and risks, and because there was concerns coming from the public in relation to risks. And the Health Research Board produced a very clear evidence-based document and assessed all of the risks in that regard and the evidence underlying it. And there is no evidence that there are risks associated. However, they do indicate that ongoing research is necessary and ongoing monitoring, which is why we have an expert body for fluorides and health in place. So that's in water fluoridation. I don't know if anybody else on the group.
I ask awkward questions, but Chairman, there are some other countries that don't do fluoridation.
Yes. That's true, they don't. And so, for instance, they use alternative methods of fluoridation. They might use salt fluoridation, they might use fluoridation through milk, they might use other schemes such as varnish programs, or they may use other access to fluoride in different ways.
And how successful are they?
They're very extremely expensive programs too, and there's also a sense of pragmatism. Perhaps you'd like to talk about that, just in that regard, the pragmatic part of it. So I'll hand it over there.
I think you're reflecting concerns that have been out in the media quite a lot. The use of fluorides in prevention of dental decay is one of the most researched areas in dental research. If you go into the search engine for scientific publications, you'll find huge volumes of research. And as regards other countries, the United States, for example, is one of the key countries. I think the figure's over 300 million people worldwide receive fluoridated water. In the United States, there's quite an amount of naturally occurring fluoride in water supplies. And in fact, in this country, we reduced the level in the water supply in 2007 because it was considered as the basis, on the basis of the research that had been carried out here, that perhaps a reduced level was better. The range now is 0.6 to 0.8. The maximum allowed in the EU drinking water regulations is 1.5. So there's a very cautious approach being taken here. In the US, they've had in the past a maximum allowable concentration of 4 parts per million, which is considerably higher even than the EU figure. So, this is something that's been shown worldwide to be effective. The problem with the other programs is, let's put it the other way. What makes water fluoridation so effective is that everybody gets it. They don't have to make any effort to get it. Whereas if you have a program such as the application of topical fluorides in some form, a varnish or whatever way it's put on the teeth, you have to get people in. They have to come into the surgery. They have to, come for an appointment. Water fluoridation is there for everybody. And that's why it's such a beneficial thing. And it's had a huge beneficial impact on oral health in this country, not just on children, but on adults who, a whole generation now, have retained natural teeth, which in the past perhaps wouldn't have happened, or without water fluoridation wouldn't have happened. So I think it remains a key cornerstone of the policy because it's a key aspect of preventing one of the main dental diseases that afflicts people. And as you rightly say, people don't look forward to going to the dentist, and that's understandable. So I think, the problem, and again, I'm sure you're well aware of it, is that claims can be made, but in the scientific world, there's a very careful evaluation done before you can talk about cause and effect. And people don't do that lightly. They want to have lots of evidence to show either that it's a positive effect or it's a negative effect. So it's a really important part of this policy, and I think it will remain so.
Thank you.
I would like to respond to your question about access to care and how we nudge people to access care before it becomes a problem. And I think the major change is the fact that oral health has to become everybody's problem, and we have to integrate the mouth with the rest of the body and work with our medical colleagues, our community nurses, midwives, for example, to pick up and nudge people at appropriate times. I think this is really important in early childhood, but I think critically in older age too. What we find is that older people for the first time are retaining their teeth. In the past, they went into older age with dentures. So I think what we see is that people make more medical appointments as they get older, but less dental appointments. But their risks are getting higher because of medicine, because of poor eyesight and dexterity and finances. So I think Pathfinder surveys, which actually look at how we can take dentistry and signpost people so that they get really good levels of oral health as they age. We know that 1 in 5 of us over 80 will get dementia, so we need to make sure that people caring, the teams caring for people with dementia, take oral health seriously, because we have the technology to be able to prevent and reverse disease if we catch it early. Our problem is that we're seeing people with dementia who haven't had any care for maybe 8 or 10 years. They're presenting with very, very advanced problems, and at that point are very difficult to treat. So I think that's a real priority. It's a new problem, but the nudges you talk mean redesigning the way we provide care. For homeless populations, we need to make it, we need to have more drop-in centres. For older people, we need to make sure things are local because they're least likely to be able to travel. So we need to make them acceptable, affordable, and design domiciliary care so that we can actually take teams of people into residential homes. Doesn't need to be dentists. We can actually work with teams of hygienists who can very effectively and very economically reverse disease. And I think this is something which is incredibly important, and I think is highlighted with the community services. We need to work with the professions and also our colleagues in other areas of medicine to design services which are going to access more people at risk.
Yes, I would just like to also reiterate on the point of water fluoridation is that Israel, in fact, like us, had mandatory water fluoridation and it was pulled out. And now the studies coming in, they did try to replace it with toothpaste studies and with other ones, as Jacinta was outlining. And for all those reasons, they cannot, their decay level has increased phenomenally. The only area in Israel that has actually maintained its oral health rates is a place that's naturally fluoridated, and all of those results are coming out. Now the water fluoridation has been taken away from them, it's impossible for them to get it back in again. And so it's really important that we protect our water fluoridation. They're stark, they're really dramatic outcomes when we see what happened with Israel when that water fluoridation was removed from them. I would like to take up on some of your other points in that regard. So with regard to the workforce, I think that's a really important point, and especially why we put in the WHO safety net surveillance network. Unlike focusing just on children, WHO is very clear. We must look at 5-year-olds, 12-year-olds, adolescents right through 15 to 19 years of age, and then 35 to 45-year-olds, bringing in, as you said, the prime ages of childbearing at this age, and then moving on into the 60 and 70-year-olds. This overlying safety net monitoring surveillance service is what is recognised by WHO since the early noughties, and all of the European countries are moving towards this direction of travel, and exactly for the reasons you outlined, to make sure that people who are in the workforce are nudged, encouraged, and have a formal nudge to come in and say, your oral health is not okay, you need to be signposted into the dentist, you need to be assured of where you're going. Certainly the view from other countries, particularly in the Dutch models, is that there was much more flexibility when it was sent out to the profession in local communities, that dentists were providing care in local communities because they could afford to be more flexible, work on a Saturday, work late if they chose to, because it was up to them to get in their patients into the clinic. Earlier stage, you can see a core part of the oral health policy is establishing a dental home as early as possible, ideally before the first year. The first 2 years are crucial, not just for the children, but also for the parents, because it has a twofold effect. You're coming in with your child, but it also is giving a nudge to parents, and there's a lot of evidence to support that. And can we be certain that certain socioeconomic groups have access to these services? Absolutely. One of the key points in the policy was to say it's a universal approach, but it must be overlaid by a targeted approach as well. That comes through in the oral health promotion programmes, but also in relation to services. At no point do we say universal access stands on its own. We're absolutely aware of the vulnerable and the people with disabilities out there, and that is why the WHO safety net service is something that we've put in place to ensure that we can pick up those vulnerable groups.
Professor O'Connell?
Thank you. Deputy, just two things again. On the other side of water fluoridation, the issue about the safety of water fluoridation, you raise, and it has been, raised. I can understand that over and over. Right across the world, in every country, and most English-speaking countries do use water fluoridation to a greater or lesser extent, have examined this over and over. And, everybody, the WHO, the EU, the Food and Drug Administration, right on down the line, have all looked at this in great detail and never were able to find any problem with the safety of water fluoridation. Our own Health Research Board commissioned a study a few years ago, examined every bit of evidence that there was out there about the safety of water fluoridation, and could find no problem with the safety of water fluoridation. Public Health England, I think just last year, recommended that more water fluoridation be rolled out in England. In fact, there are more people in England receiving fluoridated water than there are in Ireland. It's a smaller percentage of the population, but there are big fluoridated communities in the UK. The other thing, and you're so right about catching cases, serious cases at earlier ages. We talked earlier about on-demand services and children turning up in pain and infection. I mean, the question is, why are there 70,000 children turning up in pain? Why are there 7,000 children having to go into hospital to have teeth extracted? By the time they're seen, it's too late. And I would agree with Dr. Green, you do not want the first time your child coming to a dentist is because they have a big infection and they need to be bundled into hospital and put to sleep to have teeth out. Nobody wants that. No organisation, no dentist, nobody wants that. And that's why one of the key things in the policy, in line with all international recommendations, is to see children when their teeth first come into their mouth and start to give basic advice to them and to their parents about looking after their teeth, about diet, about brushing and so on. So we don't have a situation with people, young children turning up in hospital needing extractions. Absolutely, that is so important. And at a later age, we have a growing problem, for example, with diabetes. There's a well-known relationship between gum disease and diabetes. The more you improve one, the more you improve the other. And some of the health insurance companies in the United States, for example, if you're at risk of diabetes, they will pay for you to go and have gum treatment as much as you possibly want, because the more you improve your gum health, the better your diabetes will be controlled, and it stops people from going up into hospital. It actually saves them money. So absolutely, this preventive approach is what is so important and runs through the whole thing.
Not just a question of, for want of a better example, bad breath or something like that. There are serious underlying health issues with particular reference to diabetes.
Correct.
And how do we get that across to all segments of our population? Because I've criticised in the past that very often we lack information. We lack the information needed to make the necessary changes in our lifestyles to try to prevent the kind of interventions that eventually we've had to have. How do you do that?
Go ahead.
Well, encouragingly, and then I'll hand over to Professor O'Connell. Very encouragingly, from the Healthy Ireland survey, we actually looked at that. We looked at all of the different professions that are providing more general care. So, for example, in smoking, and we could see that pharmacists, dentists, medics, obviously you'd expect the medical doctor, but what we noticed was the contribution from dentists alone was 20-odd% in that regard. So it is about having an integrated approach so that we're all on the one team, and this is a key part of the policy and has been mentioned over and over again. We're stopping seeing ourselves as not just being dentists, but that we are integrated with the rest of the team, that we see ourselves as common health professionals like everybody else. So we're not stuck in a silo of just being about dentistry. And indeed, that pharmacists, there's a lot of evidence coming out from the British system and indeed from the Canadian system of the advantages that people, particularly in Britain, see the best place to receive their oral health care advice is actually from the pharmacist. And so while that mightn't translate over to Ireland, certainly there's a strong emphasis to say that information should come from several different sources. Finland, again, is another example where they've changed their system, and what they now do is that it's the first point of contact. So if you go into a health service and your first point of contact happens to be a pharmacist, that pharmacist will guide you through the system. We're not saying we're going to follow Finland. What we are saying is it's important. We're part of an overall team, but also that team is part of our team as well. We want them, other health professionals to provide dental advice, but also that we also participate in supporting obesity messages, supporting smoking messages, supporting all of those dietary messages which are so important to our good health.
Yeah, I won't repeat what Dr. Kavanagh said, but for example, the HSE at the moment have a very good programme called Make Every Contact Count, and it's an integrated programme rolled out to all health professionals, and we're doing it now and teaching it to the staff and the students, so that exactly you work together with all the care providers so that we're all providing the same health messages about smoking, about diet, about exercise and so on, and so that everybody eventually interacts with somebody, be it the dentist, the pharmacist, their GP, their community health nurse or whatever, and the important thing is that we are all giving the same messages on health.
Yes, and just a very final point to water fluoridation. I think it's important to note that when we carry out the national surveys in Ireland, they're carried out across Northern Ireland and the Republic of Ireland. And when you compare Northern Ireland and ourselves, there's a distinct difference in the outcomes in relation to oral health. And the argument would always have been that in Northern Ireland they have a much more accessible health service system than what we've ever had, yet it was water fluoridation that we have benefited enormously from water fluoridation compared to that, and I think that's a very clear-cut comparison for us.
The question of orthodontics has been an issue for many, many long years, and particularly where children arrive and they have double impacts or teeth progressing from the roof of their mouths and so on, and there's a critical age during which it is regarded as being the proper time to interact. But the pain and suffering in the meantime while awaiting for that particular age to progress can be sometimes severe, to the extent and the amount of medication taken that the child has to take in order to prevent the pain is considerable. And in some cases the conclusion is not exactly as would have been intended. And I would pose the question as to whether or not there's a procedure in place whereby you are alerted to the existence of such cases where the pain is likely to become extreme, or where the damage done in the waiting period might require rebuilding, major rebuilding of the jaw or the face or whatever the case may be as a result of delays.
In the HSE services, every child can attend, aged 15 years, up to 15 years, can attend if they have pain. In a situation where an orthodontic condition, or it's known as malocclusion, is identified, usually around about the age of 12 at 6th class, the referral will be made to the HSE orthodontic service, and if the assessment is successful, then placed on waiting list and called for treatment. Within the system, there's prioritisation given to more complex cases. But also, if a child is in pain, they won't be left in pain. Pain will be managed. And if there's an orthodontic element to the condition, the dental service will liaise with the orthodontic service and try and resolve the matter for them and deal with the pain and deal with the symptoms.
And what about waiting lists? Are there waiting lists there?
Yes, there are waiting lists.
To what extent does that affect the period during which the pain treatment has to be dealt with while awaiting satisfactory conclusion?
Well, if a child has pain through dental decay or infection or trauma or for some other reason, the child will be dealt with, will be treated in a local dental clinic. The referral to the orthodontics, as I said, has already been made. If there's an element of the orthodontic condition, the malocclusion, that's affecting the child and causing some physical pain, Well, certainly we'd liaise immediately with the orthodontic staff in order to deal with that. But that would, the malocclusion in itself would rarely give rise to pain. There could be something else going on.
There could, and that's why I'm pursuing the question. There could be a situation whereby the child may go past 12 or 14 or 16 years of age while still awaiting an outcome or perhaps very good advice. But it may well then happen that the child that was once a child is now 18, 19 years of age and is left with a sewage problem and requires major surgery to correct it. Whereas if the service and attention had been available during that window, that 12 to 15-year-old period, if it had happened during that time, it wouldn't have been severe on the child, and the outcome could have been much better. And the point I'm trying to get at there, Chairman, is the delay. The delay factor, the waiting factor. Some of those cases can't afford a waiting time at all.
Okay. Chair, I'm not an orthodontist, Chair. Primary care dentist. My understanding of this is that cases where the malocclusion is severe and the treatment will be complex may include a planned episode of surgery. These are known as orthognathic cases, where the orthodontist would work in conjunction with oral maxillofacial surgeons. The vast majority of those cases would be identified at the point of referral and the point of assessment. And then within the system that's there at the moment, those cases are prioritised. However, some of the surgery is dependent on the completion of growth. And the growth in the jaws is not completed in most instances until the very late teens. So therefore, the surgery would be planned at the end of the teens rather than, say, 12 or 13, when the majority of children would probably, that would be the optimal age for most children to have orthodontics. So in a small number of cases, the planned approach would be that some orthodontic treatment would be undertaken, possibly followed by a delay to allow growth to be completed, followed by more intervention by the orthodontist and the surgeon working together. So those cases, there's quite a small number of them, but they are dealt with within the system and they are prioritised. But they're, if you like, they're in a parallel stream to most of the other cases where priorities are given according to the extent of the malocclusion. There is quite a serious management of those type of cases, and inevitably some of those adolescents will be treated actually right through until their late teens or even early 20s because of the nature of their condition and because of the physical limitations of what can be achieved in the early to mid-teens. As I said, it's not my area, but that's my understanding of it.
Thank you, Dr. Green.
I know you're anxious for me to finish, Mr. Chairman, but I'm waiting a long time, so when one has a long drought, one generally drinks from the pool for a little bit longer. So, similarly with dental care and orthodontics, we covered the interaction with the general population. Interaction with the Dental Association. I haven't really got any great response, even though previous questioners have asked that question. The dentists in the field are working in that business every day, so they should have first-hand accounts of how progress is being made, or whether it's being made at all or not. And if they're complaining that we don't liaise with them sufficiently, or that the authorities don't liaise with them sufficiently, well, somebody's wrong, and not deliberately, but somebody's wrong, and it is to the detriment of the quality of the service, if that is the case. That's not a criticism, it's just a statement. So, Chairman, could we have a little bit further elucidation on that, if it's a possibility?
Well, I think we've probably dealt with that.
We did. We did.
Previously, unless you have some other short additional comments to make.
I noticed that my own note was that Deputy Durkan talked about us, I suppose, interacting more with the Dental Association, improving the relationship, I think is what you're getting at. We wouldn't wouldn't have a difficulty, the department, or I'm sure, if I could speak for the HSE, in doing that. I think we've come out of. I think if you look back at the last decade or so, particularly in respect of many of the people who work in the salaried health services or on the contracted services, because of some of the things have been referred to already, salary reductions and other fee cuts and so on, it probably left everyone in a sort of an uncomfortable position, and one where I suppose there was a feeling amongst those that are providing service that things were done to them, if you like, rather than that they were part of a process, which I suppose was the traditional model of engagement. So, as I said earlier, coming out of the fact that we now have a policy, we have a very good basis on which to engage, and an absolute necessity and obligation to do so.
And put in place a formal structure,
well,
as opposed to an occasional structure.
Yes, well, I mean, if we have formal business to do, let us say contractual business, there's an absolute formality or a practicality to doing that. I think in addition to that, and it's something that came out of the discussions with the Irish Medical Organisation in respect of GPs, also a necessity to have what you might call a clearinghouse for a whole lot of issues that are there as between contractors and the people who are contracting service from them. So I think that, there is a necessity to have engagements of a number of different sorts. Sometimes it's on formal, very clear, specific agenda, and other times it's an opportunity for parties to bring issues of concern to a table and work them out, and there are various models of doing that. And again, we're in the process, coming out of the agreement with the GP organisation, of putting such an arrangement in place, and it is about relationship building, I would say, and improvements have been achieved already there and will be achieved. I would see us doing the same with the dentist and other contracted professionals as well. I think that's something that it's a job of work that we have to do, and I think we recognise that.
Thank you very much. Thank you.
I just want to make just one final point in that regard, and that would be because there's a distinct difference between engaging with the dentists, and I appreciate and absolutely understand what there may be some confusion. There was absolute engagement directly with the profession, and I think it is important to note that as I said, we got massive responses when we sent out to 5,000 registrants twice, when we also had a year-long engagement that was structured, where there were structured interviews that were carried out using a very particular sample across a wide range of dentists, and they engaged in 3-hour interviews, and from that we got a massive amount of consultation. So I appreciate where you're coming from with regard to the Irish Dental Association, but I have to stand firm and say that there was in-depth consultation directly with the dentists on the ground and directly with the public. And when you look at other policies, the engagement directly with the dentists was extremely comprehensive compared to any of the other policies that have been produced. And I would hope that I would be supported in that regard. There was a lot of other consultation that was carried out with the academic reference group separately, with a separate practitioners group, and I think I just want to make sure that that's made very plain and clear.
Thank you very much, Dr. Kavanagh. Now we'll move to Senator Colm Burke.
Yep. Thank you very much for your presentations, and very comprehensive presentations they are as well. My apologies for having to leave the meeting. I had a prior commitment on another issue to deal with. I'm not sure, Chairperson, if this issue was raised, and it's about the whole area of training. And the RCSI made a point to us in relation to training about that there's no foundation year. For instance, when you are training in medicine, there is the intern year, and they're saying to us that there is no foundation year in relation to dentistry. The second issue is about the lack of available training for people who want to specialise, that we don't appear to have a structure, or that the structure that we have is not training enough people, where we have people who require specialist treatment, and we don't have a sufficient number of people in that whole area. And as regards how do we develop that whole issue about trying to improve training, like we have a lot of people who are coming out with qualifications from university who appear to be leaving the country at a very early stage, Some of them are coming back, but a lot of them aren't coming back, and I'm just wondering, how do we now work on that? The other issue is in relation to the number of dentists employed within the public sector as regards trying to provide the necessary required support for, say, for instance, for children going to school. We were advised that some children might actually be in 6th class before they have any dental examination, and I'm just wondering, how do you now deal with that issue? And the final thing I have to say is just in relation to the development of primary care centres. And there's over 120 of them developed across the country. I'm just wondering how many of those primary care centres we're talking, because dental health is an important aspect of people's health. I'm just wondering how many primary care centres have put in facilities for dentists to operate in, because I'm not sure if that has occurred. Where I've seen, I've seen new primary care centres open with facilities for every other section of healthcare, but not for dentistry. And I'm just wondering, has there been any lobbying done on that to try and make sure that when you're rolling out a primary care centre, it's all health areas, including dentistry? And I'm just wondering, could we have some figures in relation to primary care centres about the number that have capacity to accommodate dentists, because I'm not clear that there is that provision being made. So that's just my initial questions on those issues.
Thank you, Senator. With regards to the training, yes, I mentioned this in the statement, and it's certainly something that the reference group and is contained in the policy. Obviously, if you want to have a good and a functioning primary care system, you want to have a good ecosystem, you need to have people trained at primary care level, and we've spoken a fair amount of that. But then you also need people with special skills who can treat the more complex patients and also provide the training for the people on the ground to be able to see the widest number of patients possible. And those are the specialists and academics. And indeed, some of that has been hollowed out over the last 10, 15, 20 years. Back when we had the Postgraduate Medical and Dental Board, in fact, it was medical and dental, and there was actually more attention given at that point to having a kind of a structured career through dentistry. When that was disbanded, when the HSE was set up, it sort of feels like a lot of that responsibility for further training in dentistry, in specialisation and in academic pathways seems to have dissipated, and we have spent a lot of time over the last years trying to find it, and we don't know where it's gone. So certainly we do need to put specialist training and kind of consultant academic training back on a firmer footing, and that is recognised in policy.
But do we have a 5-year plan, say, to do that? Yeah. Like, it's important that, it's great to present documentation and to talk about it, but I'm just wondering, have we a clear 5-year plan with clear targets on that?
Well, I'll let the department or the HSE talk about that, but I would say this, and you're right, we talked about implementation, and it's recognised, and I think we would be very clear, this does need to be implemented altogether. If we ask dentists to start seeing children in practice or people with disabilities, on Monday morning, by Monday afternoon, they're going to have a need to contact a specialist in some cases and so on. So absolutely, it is critical it be rolled out together.
Yes, absolutely. I very much welcome those points and an opportunity to talk about that. We worked very closely with the Dental Council, and indeed they set up a separate working policy group to work with us, and this was particularly around the areas of education and training. We are very proud of our graduates. They're fit for practice. They hold their own amongst all of the European graduates, and I think that's very important to say. But what was clear in our consultation, indeed, that came back from the dentists, was to say that they want primary care at the heart of it, and as you articulated, that they want to have more exposure to practice, more exposure to all of those areas of managing their own practice in primary care right through their graduate programme, and they weren't necessarily convinced of those that we asked that what is being proposed in foundation training, as it was then called, would solve, rectify their problems. In fact, in the older graduates, they said, no, we're still having problems. And that was why we started to look at it, moving more towards a mentoring programme, which I suppose is a super extension of that programme. Let's focus on the specialist side of it, because I think that's a very important area. The Irish Committee for the Specialist Training in Dentistry, which are the formal recognised group to bring as part of the Dental Council over specialist training, have welcomed this policy in writing and very supportive of it. We have already started working with the Dental Council and the ISTD to put in place advanced centres of care. That involves not just a name, that involves credentialing, looking at the work, how much workforce we need at all of the different levels. Specialists in Ireland are different, or specialists indeed in Europe in dentistry, are different to in medicine in that they are independent practitioners, which is not the case in medicine. And so that makes a very different dimension to our workforce. It means that what we need for consultancy, unlike in medicine, it doesn't mean that you automatically jump into consultancy. We've this very firm grade in between. So this is a piece of work, and they are well placed to lead in it. In fact, they've done a tremendous amount of work already to prepare for specialisation and for the advanced centres of care coming through. So we're not, when we're talking about it being a 5-year plan, this is a priority for us. Education and training, mentoring, and then moving forward into the advanced centres of care and credentialing those. This is a key piece of work with the Dental Council. We've met already, and the working group is starting to get going in July on it. We want to start commissioning out certainly early next year to look at our undergraduate training in the first instance, but we've so much groundwork done on the specialisation, great leadership there. We hope that we're in a very strong position to move them in parallel.
And the issue about the foundation year?
And that's the mentoring scheme, as I identified. We want to get more of, instead of leaving it all to the last minute and leaving it into the last year, because the skills start, dentists start using their clinical skills right through. We want to get more of that into the undergraduate training, but we recognise it's jam-packed already, that we're going to need to have a mentoring framework afterwards. But we're not naive enough to think dentistry changes very fast. Every 5 years it changes. So it's not just for new graduates, it's for all those other graduates that are out there. And we've looked at psychology, as I mentioned before, we looked at social work, looked at other systems that are in place for long-term mentoring, and this is the position that we're looking at. So it's like a super extended type of foundation training we're looking at.
But of the number of dental students coming out at the end of the year who graduate with a degree,
yes,
what percentage are actually staying in Ireland and what percentage are leaving in the first, just immediately after leaving? Because, if you come out with a medical degree, you'll do an intern year here, whereas what is happening in relation to dentists who are coming out?
Well, what is, I'll refer back to my colleagues in this regard, but one of the issues that has been raised is about they want to have the opportunity to use all of their skills, and the current public system would be arguable, and it came from the dentists themselves. When we consulted directly with the dentists in the salaried service, they indicated that they had concerns about they hadn't the opportunities to broaden their skills. Perhaps others can pick up
But what I'm
on
asking
that.
is, of the numbers coming out of dental school, what numbers are actually physically staying in Ireland once they come out of dental school?
And I think you have the answers to that for me, I hope, in that regard.
We don't formally keep track of those numbers because we have no particular mechanism to do that, but it's highly dependent on the state of the economy at the time. So during the recession, when there were no opportunities here, the majority of people did emigrate. At the moment, in the last couple of years, the majority of graduates will stay here because they can work and they can go right into practice. But just to be clear about the foundation training that you asked about and what we're talking about, as has been mentioned, when dentists graduate, the system, the way it's designed, that has worked very well, is when dentists graduate, they have an excellent set of skills that enable them to do a wide range of things. And there's no evidence that there's really any difficulty with that. I mean, if you go down to the Dental Council and you look at the problem, at who's coming before fitness to practice, or you look at complaints from the public, you look at any metric, and we have a whole series of them, There's really no problem with new graduates. In fact, in many ways, they practice, maybe better and more safely than established practitioners. What they don't have is they don't have the widest range of experience of treating a wide range of patients that we've been talking about here in terms of, say, people with disabilities, very young children, people living in residential care. And if we're looking at something that we call an extended, year or foundation training, I think we have to look very specifically for an Irish system as to what is the gap that is needed to fill here. So I would definitely agree we need to look at extended training in a mentored environment, as was stated, but I don't think we should replicate exactly what's been done in the UK, because it's not fit for purpose, and I think my colleagues in Cork would feel the same.
But wouldn't it be important to establish, of the numbers going through, the cost of providing the degree course is, it's a fairly big cost to the state. Wouldn't it be appropriate to now establish, like over the last 10 years, what percentage of graduates who graduated over the last 10 years are now in Ireland? What number have left? At what stage did they leave? Because I think one of the problems is, we're giving huge funding to universities, and it's about a return to the state as well in relation to that investment. And the question is that if we're educating a huge number of people who are leaving, then we need to ask the questions. Number one, what do we need to adjust in order to make it more attractive for them to stay? And then, and it's not just staying for 1 year, but thereafter. And yes, if they need to get further experience by travelling abroad, then we need to work on that as well. But it's just an issue that's coming up, where, as we're facing huge challenges in a whole range of areas in the workforce now where there's a shortage of people. And what I don't want to have is that there's going to be a shortage of dental practitioners because we haven't responded to their needs once they come out of college. And I'm just wondering, is it not appropriate at this stage that we would try and find out, what level of return have we got in relation to that investment to dental training?
Yeah, I couldn't agree with you more. I think it's a very fair point. But, as in medicine and other areas, it's a little complicated because, the flip side of that is, why do people leave? And if you can't get a job here, you could hardly blame someone for leaving, and then other people go because they want training opportunities that you spoke about before that are not available here, so their intention is to leave and come back. So absolutely you're right, but the reason people leave, the reasons are complex.
I would also like to raise, in relation to the policy development, we undertook workforce analysis, and in fact what was of particular interest is that of our new registrants coming in every year, almost 40% of them are coming from European outside of Ireland into the state. And as you rightly say, we do have a registration of Irish graduates, but it's important to note that many of the students within the dental schools there's an agreement with Canada, and they provide a substantial contribution to the education aspect, and there's also from other countries as well. And so when we talk about people graduating from Irish schools, it's not necessarily that they want to go back to Canada because that's their home, or they want to go back to other areas they came over for their education. And there's phenomenal amount of EU mobility. We do see that when people come in from the European states, they do stay, a sizable majority, and I have the figures available, will stay beyond 5 years and 7 years. I think we're coming back to, within the policy, aiming on this point of giving graduates more opportunities to have a breadth of skills right from the time they graduate, and having that mentored environment for them. As I said, not just for 1, 2, 3 years, but it's the first year that's a benefit, but it's much more long-term than that, to help them to establish into practice, to, after 5 years, set up principalships in practice. This is all knowledge that nobody's going to get overnight. And so it's really important that we focus on this mentoring framework long-term. Many other professions have done it. We're a very isolated profession, and that very clearly came out when we consulted with the dentists. When we went out to them, what they said, in rural environments in particular, they felt very isolated from their peers. And that fundamentally changed the way we were approaching education. Said, okay, we need something much more substantial than just 1 year programme after this. I think it's also important for my colleague CDOs, for my colleague Chief Dental Officer in Britain to mention, and she's very firm on this point, it's an NHS scheme. It's not actually an education scheme. So it's not an intern scheme in that sense. And I think it has been somewhat misrepresented. And she constantly berates me over the misrepresentation of this. In the United Kingdom, it's linked to NHS practice and it's only attached to that practice. If you're going into private practice as a UK graduate, you go out into practice similar to every other European graduate. So it's only linked into the NHS system.
Yeah. Just on the primary care centres, have we any kind of information on that?
So in relation to, only from the policy perspective, and then I'll hand to my colleagues in the HSE. In relation to the policy perspective, we've talked very much about integrated care and the importance of us being part of an overall health team. So certainly all of the indications in all the support in the policy is that we would be seen as primary care members and that would be on the equivalence of the other health teams. And then I'll hand over to my HSE colleagues.
So of the primary care centres that you mentioned, there's a number of them have dental clinics. I don't know the exact number. I'll get that for you. It's a small number of the centres that have been developed. What they do take account of is the earlier development of primary care centres focused on the core team, mental health and so on was added then. In more recent development of our guidance and so on, as we progress, we're taking account of what the overall accommodation needs are and in a particular location, and in those circumstances a wider range of services can be provided. But that's in more recent times. I'll get you the exact figure. I think it's a small number would have dental services in them. Dr. Green will just set out the position in relation to there's about 221 clinics we have around the system, and they're very much locally based and would link in and be seen very clearly as we move forward with the development of network of services, will be very much seen as part of the team.
No, I'm just thinking of just the primary care centre just recently opened in Cork and in St Mary's campus in Granabrower. You know, it's servicing I think 42,000 of a population. Right. I'm not sure if there's a dental unit.
There is, yeah. I think there is. There is, yes. A large one.
There is a dental.
Yes.
Yeah, okay, because it wasn't, I think it wasn't given to us as part of the briefing when the opening was being done that there was dental facilities there.
My understanding is that I'm not certain that it's fully commissioned yet, but it's in place.
You might come back to me.
I'll come back. I'll also come back to confirm the number of primary care centres with dental facilities. Right. We have 221 locations. That takes account of over 400, I think it's 430 dental surgeries. The nature of dental equipment and the standards that have to be met with regard to the safety of dental equipment, infection control and everything is up to speed, is such that tend to take a 10 to 15 year view of installing a dental surgery. So if you're in a situation where a dental clinic is in existence and a primary care centre is being developed on the same campus, it may not be appropriate to include the dental in the same facility. And if I give you an example of Ennis, I think 2 primary care centres are planned for Ennis, but 1 will have dental. So you wouldn't necessarily duplicate the facility. Okay. So there are solutions that are appropriate to each location.
All right. Just finally, can I just ask, in relation to the total number of dental graduates who are coming out every year, what kind of number are coming out every year from our colleges now?
We have 48 a year in Dublin, approximately 1/3 of whom are non-EU and 2/3 are EU students, and Cork have broadly similar numbers. Some years there are as many people register with the Dental Council from outside EU. It's a very mobile population. Yeah. So some years we may have 80 graduates here, but there have been years where there have been over 100 new dentists register here from other EU countries. So it's a very mobile workforce.
Right. Thanks very much, Senator. And before I bring in Deputy Culnan, just a few questions in particular to the Department and the HSE. In relation to dentists who are working in what we would call private practice or working within the community, what percentage of those hold a contract to supply public services through PRSI and other contracts? And is there any move to reverse FEMPI for dentists? We've had a move to restore funding towards general practice in the last number of months, but I don't think there has been a move to restore the FEMPI reductions to dentists, so perhaps you might comment on that. And in relation to the overall strategy, what funding is going to be needed to fund the implementation of the oral health strategy? Because what's the funding for at the moment, and what's the increase needed? Because in relation to Sláintecare, we have been battling with the amount of money that's going to be needed to implement Sláintecare, trying to determine how much money will be needed each year and when that money will be released. So perhaps you might just respond to those questions. The other then is in relation to orthodontic waiting lists, public orthodontic waiting lists. I think you said that there are 13 public orthodontists, is that right? What number would be needed to clear a waiting list of 1,800? Because there seems to be more people waiting than in treatment. And surely the way to address the issue is to increase the number of orthodontists, rather than using private dentists to pick up the slack through a national treatment purchase fund type mechanism, which really isn't addressing the problem. National treatment purchase fund mechanisms are trying to fill the gap rather than address the actual problem. Then in relation to special needs, and Dr. Dougal, you might talk about this, where is treatment provided for very complex special needs? Because we probably all have patients who can't have that delivered through their community dentist. And is it through the dental hospitals, or is it through the general hospital services? How can people get that service, and where do they get them? And we have had a submission here from the dental hygienists, and their main point in their submission is that they are entirely focused on prevention, and they don't seem to be involved in the oral hygiene policy, or maybe they are. Where do they fit in to the oral hygiene policy, particularly in relation to prevention? Yeah, they're my questions. Thank you.
Regarding where people with disabilities seen, well, there's 643,000 of them who self-report with a disability. So I think the answer to that is everywhere. But we would say that there's probably about 13,000 who at some time would require complex care. The truth is that the access to services is ad hoc. I mean, that's a large number of patients who are particularly at risk. So there are a relatively small number of people currently in Ireland who are trained specifically to see these groups, and I think that is an issue. And access to general anaesthesia is, again, ad hoc. There are some pockets of brilliance and some pockets of excellence within Ireland, but in other areas there is nothing at all. So we have the instance where people would have to travel great distances, to example, to the dental hospitals or across borders. But the dental hospital is not an acute setting. It doesn't have general anaesthesia facilities. So I think really the answer is that general anaesthesia is provided throughout the country, but it's severely limited. And many people with disabilities have their treatment options severely limited by poor access to general anaesthesia. For example, extraction-only services, or within that general anaesthesia setting, they're not offered root canal to save even a front tooth. So I think the honest truth of that is there are no well-defined care pathways, and there are not enough people currently trained to provide. But I think that is well addressed, that there is a need for that in the policy, and undoubtedly there's going to be a need for more people trained in this area. Back to the training at undergraduate, I think evidence has shown us that we can train people in general practice to do the bulk of the work. But undergraduate is not the time really to work on complex patients, because people are honing their basic dental skills. So I think the mentoring after qualification for this group is extremely important. Special care dentistry is a specialty. We offer internationally 3-year specialist training. At the moment, most Irish graduates in this area are travelling overseas to get their training because of the cost of the training in Ireland. And unlike orthodontics or periodontics, where people can go into general practice afterwards and earn their living, it's very difficult at the moment to actually self-fund a very expensive course of treatment. For me, succession planning, I'm a consultant, but there is no formal recognition for a consultant training pathway to, for example, replace myself when I retire in 10 years. So I think training this area across the board is really priority, and it's been recognised that it's a priority. So I think it's possible to achieve very good levels of care for people with disabilities. We can see that from the literature. However, this is going to be a challenge, but it's a challenge we know is possible. And the evidence is there to show that the training is available in Ireland, and we have the methodology and the curricula to train our undergraduates and our postgraduates and people who are already in practice, to give them the skills to prevent the need for the extensive treatment. We're always looking to prevent general anaesthesia, and I think prevention works extremely well for people with disabilities. We need general anaesthesia there. We need people trained to provide sedation, which opens up far bigger options of care than general anaesthesia. But in the most, we're looking to prevent this by good, well-orientated preventive services in primary care.
When the Royal College of Surgeons was here in May, they made the point that there are only 2 dental specialties recognised by the Irish Dental Council, whereas in England there are 13. So is that going to be addressed within this oral health policy?
Regarding, special care dentistry in other countries, is a specialty, along with many, many other specialties. I just wanted to make one comment. Retention of staff or training of staff for people to treat with disabilities needs a career structure the same as every other specialty, because that's going to help retain people and get them interested in that. But as far as the policy, I'll hand over to Dimna. Thank you.
Above my pay.
Thanks very much, and thanks, Mr. Chairman. Yes, indeed, in the policy, first of all, on the specialties, the EU recognises 2 specialties across the EU, and we have conformed with that on oral surgery and orthodontics. In the UK, in particular, they have a plethora of specialties. There is a lot of debate, particularly amongst my Chief Dental Officer colleagues, about the merits in smaller countries such as ours, where you have 4.5 million people, for people to have, if you're in a very specialist, limited area, to have the body of work to maintain your skills. And that's a real dilemma for us. Certainly if we look at the Scandinavian countries, which many look to first, they have developed a concept of specialist generalist training, where they're moving away from very limited specialties and then saying, so for instance, and I'm only taking it as an example, and certainly I would not preempt what will come out of the policy, so that perhaps they start to combine 1, 2, 3, several specialties in together, particularly for the rural areas, and which is a real challenge for us. It would be very difficult for us to appoint a paediatric and a special care and several specialties, or indeed get people to work in those areas. So let me come back to the policy. The advanced care centres, which is credentialing that. Certainly on a national level, we would need to have a broad range of specialties that would be available to us. However, if we're looking out into the community, we would have to look at that workforce planning in a certain way. It's important that they maintain their skills. It's also important, and one of the concerns in the consultation with the dentists on the ground was to say, we're primary care dentists, we have a broad scope of practice, and we feel we're being eaten on one side by the specialties coming in, and we're eaten on the other side by the auxiliaries coming in. We want a clear definition of our scope of practice. And the view from the Dental Council would be, everything is in primary care unless, as Alison rightly points out, it's a very advanced part of care, and we need this networked care. So it's a mutual relationship. We only have 2 specialties at the moment. We are in confirmation, we are conforming to EU. We recognise that we need to have more specialties in key areas, but whether we would go as far as 13 specialties, we don't have 78 million. I'm not sure that would be the appropriate model for us, but certainly looking at those key 4 pillars, primary care, special care, looking at public health and looking at the advanced centres, such as in the areas of restorative and perhaps periodontal care, those are key areas for us when we look at the needs of our communities to look at, and that is our first port of call.
Thank you. And, sorry, Dr. Green.
Sorry, Chair, I was just going to take your other question.
Yes.
The DTSS, there are about 1,400 active contractors, and last year the DTSS cost, treatments claims cost just under €60 million. That's covered.
And that's out of a total number of how many dentists?
There are about 3,200 on the register, but that wouldn't equate to the workforce.
Okay.
Okay.
So
Given that some people
1,300 hold a contract?
Just under about 1,400 active.
Okay.
There might be a slightly higher number, but some of the contracts may not be active. About 1.1 million treatments at a cost of just under €60 million for just under 390,000 medical card holders. The uptake rate in that scheme is about 31%. So 31% of adult medical card holders attended the dentist last year. At least that's what we have visibility of. The treatment benefit scheme, I don't have figures on expenditure. My understanding is that the cohort of dentists, about 1,600, it might be slightly higher, but that's the same group. The 1,400 would be a subset of the 1,600 by and large.
Okay.
I would just like to make a comment from our colleagues in social welfare in that they've had a huge upsurge in take-up of contracts, and as Dr. Green rightly pointed out, because they've had a change in their scheme in the last year, and so they would now far surpass the number of contracts that they held before. They've also noted that a lot of dentists who were previously entirely private and not in the medical card system are now opting to be just in the social welfare system. So that is a challenge, and that's why we're working so closely with our colleagues in social welfare in that regard, because there's now quite a difference between the numbers that are taking up the social welfare contracts vis-à-vis the medical card contracts.
And what were the changes?
They introduced a preventive, they introduced both periodontal care, and they also introduced scaling and polishing.
Okay, thank you. And just before I go to the rest of my questions, Deputy Culnan has to leave, and he has been very patient this morning. So we're going to give you an opportunity to ask some short, succinct questions. Deputy
No problem,
Culnan.
thank you. Look, I'm not a member of the committee, but I have a number of questions I wanted to ask, and thanks to the Chair for his indulgence. First of all, how does somebody get referred to an orthodontist, a public orthodontist? So what's the referral pathway? Mr. Green, could you answer that for me?
Sure. Child is seen through the dental service run by the HSE, and the HSE dentist assesses whether there's an orthodontic treatment need, and if there is a system called the Modified Index of Treatment Need that's used, and if the dentist assesses the child and leaves the condition or the emerging condition is likely to be accepted for treatment, the referral will be made. Then the assessment is made by the regional orthodontic department.
Okay, but I would imagine if somebody is referred to an orthodontist, they are referred for a good reason. And even if it's for a routine inspection or for a routine treatment, it needs to be done. So I think Ms. Dougal talked earlier about nudging people to make sure that they get treated as quickly as possible. And Ms. Kavanagh spoke earlier as well in a similar vein. So just maybe either to Ms. Dougal or Ms. Kavanagh, if you were referred to an orthodontist, how quickly should you make sure that you get assessed, you get seen, you get your inspection, you get your treatment, whatever is needed? If, for example, you were referred but you left it on the long finger for a couple of months, for 6 months, would that be a wise thing to do?
Sure.
If I could just ask maybe whether Ms. Dougal or Ms. Kavanagh first to respond to that, if in terms of making sure that a person gets either the treatment they need or the inspection is carried out to see what the problem is. If you are referred to an orthodontist, I would assume the referral is made for a good reason. How important is it that that person is seen as quickly as possible, I suppose, is my main question.
Well, with regard, I can speak on behalf of the policy.
Yeah.
I'm not, want to be clear that I'm not speaking on behalf of the service.
Yeah.
And so when we were looking at it with regard to policy and in line with Sláinte Care, yes, the intention would be that assessment would happen as quickly as possible. We've talked quite a lot about advanced care and the importance of specialist care, but one of the key points of Sláinte Care is to ensure that as much as possible can be carried out in the local setting and in a primary care setting. So this is a real key task for the Dental Council, indeed for all secondary care services, but also orthodontics, to look what elements of orthodontics can be appropriately carried out within a primary care setting to speed up that situation. That's the type of service that's provided in other European countries when they do provide orthodontics. And indeed, even in the UK, which has very traditionally been a specialist service, they've now looked at many of their service treatments going out where possible and where appropriate. I'm not for a moment saying the advanced care services, but where possible and appropriate, the Dental Council is going to look at that in conjunction with the Committee for Specialist Training.
And if I can just come back maybe to Mr. Green, because somebody earlier raised clinics where people come to us obviously with a range of different issues and ask us to raise issues of concern to them. Orthodontics sometimes is one of those issues, and I know in the southeast more so because the wait times are higher. So I did put a parliamentary question in, which I think you responded to, Mr. Green, around wait times in the southeast, and I have to say I was taken aback when I got the response. And it was broken down by year from 2014 to 2019. So for routine treatment wait times for orthodontics across the southeast, the average wait time in 2014 was 42 months. The average wait time now is 60 months. And if you look at my own constituency in Waterford, 2014 37 months, 2015 47 months, 2016 51 months, dropped back to 47 months in 2017, possibly because of the national procurement process you spoke about earlier. 2018 back up to 54 months, and now 60 months. So how could 60 months be an acceptable wait time?
I don't believe it is. It's not.
And why is it 60 months? What's the problem? How could 60 months, so we're clear, is 5 years? How could that be possible, that somebody has to wait 5 years for an inspection, which I assume is the case? And even then, in terms of delays in calling for priority wait times, it was up to date in 2014 and 15. It then went to 9 months in 2016, 13 months in 2017, 16 months in 2018, 18 months in 2019, a year and a half for priority cases. And for me, they're astounding figures. So first of all, we talked earlier about policy. We heard a lot about policy. We heard a lot about encouraging people to go and get checked up to make sure that they get the treatment that they need as quickly as possible, nudging people, supporting people, raising awareness. But if the capacity is not there and the services are not there, and for a routine appointment it takes 5 years or 60 months, and for a delay in what's called a priority takes 18 months, makes a mockery of the policy if that's the case. So why is it that people in Waterford, and by extension the South East, because the numbers are very similar, have to wait 60 months for an inspection and 18 months for more serious cases?
Okay.
What's the problem?
The problem is one of capacity. The capacity of the system.
It's capacity for 5 years. So why was it not dealt with over 5 years? If it's going up and up every year, surely the people then who are tasked with making sure that wait times come down are putting the solutions in place. So if something is a problem for that length of time, then the people who are responsible for making sure that the solutions are put in place are obviously not doing it, because they're going up. You've acknowledged that. The wait times are going up, not down. So if it's capacity, what capacity specifically? Is it orthodontists?
It's the number of orthodontists, and thankfully there's been some recruitment in the South East. An orthodontist took up duty in April in New Ross. The The number of orthodontists be needed there is much higher than is there currently. But as I said earlier in the answer to Deputy Brazel, in order to increase capacity, we either increase the number of specialists or increase the number or introduce the grade of orthodontic therapists and provide the appropriate number. And that's in our workforce planning at the moment, the introduction of the grade of orthodontic therapist.
And see, what's frustrating for me, and I'll finish on this because I know you want to come back in, Caherla. I listened to us here for about an hour and a half, and I thought Ms Cavanagh's responses, Ms Dougal's responses were first class in terms of setting out the policy, setting out a vision, setting out what needs to be done, setting out in very clear terms, but also important terms, what people need to do to look after their own oral health and dental health and so on, and also from others as well here. But it does make a mockery of policy, does it not? If in the South East there's a 60-month waiting list, 60 months, 5 years to see an orthodontist, and then we're up to date in 2014 and 15 for the priority cases, and they would slip back to 18 months. So it's hard to sit here and listen to, you know, all of what's been said about policy when the reality for people is somewhat different, and it is then children who suffer the most. If you're waiting 5 years and it might be your routine, I would imagine if it might be, you know, you're referred for a reason, it might be a routine reason, but over 5 years, if it gets worse, that person, as was said earlier, that person is 13, 14 when they're referred, could be 19 before they're seen. It just seems to me to be outrageous, and it's very difficult. You know, I commend the people who are very passionately champions of the policy, but policy is one thing. The implementation of that policy, the outworkings of policy, and what's available for people, in my view, in the South East, seem to be two different things.
Dr. Kavanagh?
Well, I think this highlights exactly why we say there's a need for change and looking towards the other European countries. Technology has changed enormously in dentistry, even in the last 5 years. You only have to walk down the high street to see how many private dentists out on, not when I say private dentists working in practice who are providing orthodontics. This was undreamt of before. I'm not just talking about orthodontics, I'm talking about implants and other areas. I'm not talking about in the advanced areas. Absolutely, we need our specialists for those areas. But it's very important to see what we can put out reasonably and appropriately and supported by our specialists and by our consultants out into the primary care setting. I'm not just talking about orthodontics, but you're absolutely right. I think that's a very clear example of why we need a new way of looking at features. These model has worked excellently for us. We have excellent oral health in Ireland, but it is a model that needs to change now. As you say, we just can't keep up. Changes in technology have now allowed us, the facilities, to look at it in a different way. Make sure that where possible, where appropriate, people in Waterford can get access through their local primary dentist with support. And that's key, with support from the specialists and the advanced centres from the community dental services. And this is what we want in the policy. And that's why we're so keen to start, and the advanced centres of care so quickly, so we have those specialists in place, seeing the dimensions of their job, not just about treatment, but about mentoring and about support. But also that primary care dentists have the opportunity, and in consultation, they were adamant, we have the skills, we want to use all of our skills and provide such areas in other areas of secondary care. They just need to have the support for it. It's an urgent piece of work. It's a priority in the policy. We must move forward in that direction. I think we would, yeah, in all of the areas of secondary care, let's move forward with the rest of Europe, and let's take it forward.
And maybe just one final response for Mr. Green in terms of, you've mentioned capacity. There is a capacity problem, and you've said that there has been some additional capacity. And is that additional capacity enough to reduce the wait times? And if it isn't, what more is needed?
What more is needed is a comprehensive workforce plan, not just for the South East, but for the wider orthodontic service. Getting the skill mix, the correct skill mix within that, across consultants, specialists, and orthodontic therapists, as I said, and dental nurses. Can I also say that the staff do a very fine job, and the outcomes from our orthodontic treatment are very good. I think that should be said as well.
Thank you very much. But just to go back to what Deputy Cullinan is saying, there is a huge dissatisfaction among the public, among parents of children who have to wait a prolonged period of time, and quite often there is no end to when you'll be seen. You're put on a waiting list, but you have no idea whether it'll be 1 year, 2 years, 3 years, 5 years before you'll be seen, and that creates great anxiety among patients. So what patients end up doing then is borrowing, stealing, remortgaging their house, putting themselves at huge financial risk to try and get the service that should be provided through the public system, but is not being provided, and they then go privately. And they may have 2 children or 3 children who need orthodontic treatment. It might not just be one, which puts them under serious financial pressure. So I think that's the issue. The policy is fine, and the intention to change the policy is fine, but the practical reality is, as Deputy Cullinan said, the lists are growing rather than reducing.
And I think that, Chair, that's acknowledged. I mean, Dr. Green has said that from the HSE's point of view. It's clear to us that there's a particularly enduring problem in orthodontics, so there has been a recruitment and retention issue. I think Dr. Green and the team involved have done a significant body of work in trying to bring forward solutions to improve capacity, and I think he's gone through that. The workforce planning piece is important. This idea of the therapist now, the orthodontic therapist, I think that is something that could contribute, and so on. So I think it's to be acknowledged, and the points you make are understood. A lot has been done to try to address the capacity position in order to improve the situation for the service users that are waiting. We do prioritise the highest number. There's 18,000 in treatment at the moment. That's not adequate. There's another 18,000 on waiting list, so that's fully understood. And I think just to say that, but there's a significant amount of work has been done by the profession and by the clinical lead, Joe Green, here to try to bring forward proposals to deal with that, and I think that's what we'll try and do.
Professor?
Just briefly, Chairman, on this, and I really do sympathise with the HSE, because when they had the system working, it works very well, and they're right, they have dedicated people. But it comes back to the point we are trying to make about all of this needs to be implemented together. Essentially, specialty training has fallen apart. So you have people training as orthodontists, and if they want to train here or abroad, they're paying for their own education. Say in Dublin or Cork, it's like €25,000 a year for 3 years to train as an orthodontist. Well, then it's impossible to attract those people then back into the public service, where, particularly when salaries have been cut. It's just simply not an option. So we are training the people, but they're paying for it themselves, and so there's absolutely sort of no attraction for them then to go into the public service, and here's where we need some joined up thinking. Similarly with the orthodontic therapists in Trinity, we set up, specifically at the request of the public service, we set up a training programme for orthodontic therapists. And then the health service is not employing orthodontic therapists. So we have private practitioners lining up to send their staff in to be trained as orthodontic therapists to go out and work in private practice, but they're not working in the public service. The public service is not employing them. So, this is what we need, this joined up thinking, and it needs to be implemented sort of all as one, or, it won't work together.
Okay, thank you very much, Professor. And to go back to one of my original questions in relation to the funding of the implementation of this policy, and a particular question in relation to the reversal of FEMPI.
Okay. Although you use the term restoration of FEMPI, I think it's important to note that the mandate that the department and the HSE would have, were we engaging in a fee discussion with dental professionals, would be about modernisation, reform and service development, and that would be the context in which the government may commit to additional funding. So there would not be a mechanism which is just about undoing a fee change and changing nothing else. So that is the basis on which we would engage, and that was the mandate we had in relation to general medical practitioners, as you're probably aware. So I'm not saying that in a negative way, but I'm saying that would be the basis under which I would anticipate we would be mandated to go into such an engagement. So that I think in the context of the implementation discussion that we've referred to earlier on in this meeting, I think that's where the fee construct will come into it. You asked as well about the funding implications of the policy and the costings, which are, subject to, obviously, to evolution over time, are that over an 8 to 10 year period, and looking at current fee levels and so on, we would see it as probably in the region of 80 million would need to be committed. In practical terms, and we've heard quite a lot of discussions here about resource issues of one sort, and some of them are structural, some of them are resources, and we all know that the health service is challenged all the time in relation to living within resources and finding the resources to do additional things. So the process in relation to decisions on additional funding will be, I would imagine, essentially annually in the context of each year's estimates. So again, as I said earlier, we have a job of work to do to construct the proposition for a contractual engagement, and in doing that, obviously going into that process, we would need to have the financial, the understanding that the money will be provided or can be provided when we come with an outcome from it, which is again what we did with GPs.
So in the context of the 80 million, what's the cost of providing the dental services at the moment?
The DTSS, that as Dr. Green referred to earlier, is in the region of about 60 million per annum.
And all of the services are around 60 million as well.
And then you're talking about an additional 80 million to develop the service and develop the policy.
Yes, that's
over 100% increase.
A multi-annual, spread in a multi-annual way. So it's substantial enough, but I suppose in health service expenditure terms and spread over a number of years, I suppose it shouldn't seem insurmountable.
And in relation to dental hygienists, where do they fit into the picture, or what function do you see them having in the policy?
Yes, I'm glad you raised that, because we met particularly with the professional group, the Irish Dental Hygienists. In fact, we met with them a few times, and we're meeting them in July as well. I would have thought they were, they are key parts of the policy. We met with the Clinical Dental Technicians Association as well. I met them 2 weeks ago, and in that regard we would see these are the two key groups of the auxiliary groups under the new dental legislation that will be independent practitioners. So I suppose a key issue for us is the opportunity for them to take on independent contracts if they so wish, and particularly when we're devising the packages of care, looking at the Dutch system in particular, which embraced in auxiliaries and therapists in this way and other groups. That was exactly how the construct was, and so we had a mind to the new dental legislation to bring in these independent practitioners. I think there was a concern that was raised from the CDT, from the clinical dental technicians, that it would be a backward step, and we were saying absolutely no. In fact, it was with all the intention to expand the scope of practice where possible of auxiliaries, and we've been very clear about that in the policy. Where it can be expanded, it should be expanded, being mindful of the benefits and risks which the Dental Council would be aware of as a regulatory organisation. And they are two of our independent professions that we would see coming forward, so it will be extremely important and key to the policy and provision of care.
Thank you. And one last question. In relation to implementing this policy, what legislation is needed? Will there be legislation needed? And how far advanced is that legislation?
The legislation that we refer to is for continuing professional education. There would be legislation required to make it mandatory. It's not to say that they can't undertake it at the moment. Then within the legislation itself, also for hygienists and for the independent practice, we would require legislation not for the clinical dental technicians, but indeed we would require it for the hygienists. In relation to the independent to student registration is another key aspect. We haven't discussed it here, but we're looking at student registration as well, and that would also be for continuity of care and for other reasons. Education and training is currently just specifies 2 dental schools. One of the issues we alluded to, is the increase in numbers of European graduates coming in, but we also have private schools in Ireland as well, and the Dental Council doesn't have jurisdiction over those. In fact, Europe-wide, we have a huge increase in the workforce of dental graduates, but they all are from a very variable mix, but the Dental Council, so we need legislation in relation to that. Registration and inspection. The Dental Council currently doesn't have the wherewithal to go into premises and inspect them, and Dr. Green alluded to the need for us to have high quality standards in relation to dental care, and indeed the HSE salaried service is exemplary in that regard. But it is important that for all premises and practices that the Dental Council can put in a programme of work whereby they can inspect practices in that regard. So the main issues are for the policy are the CPD to be mandatory and the registration and fitness for practice for the 2 key groups, initially hygienists and of course maintenance for the clinical dental technicians.
So the Dental Act of 1985, will that need substantial review then?
It's already been undergoing, it's already undergone substantial review. All of the public consultation has been undertaken, and work will gain more momentum once the Regulated Professions Health and Social Care Amendment Bill completes its passage through the House of the Oireachtas. I mean, they've been very much tied up with that bill, as you can appreciate, but all of the infrastructure is in place to now move forward with that legislation. We'd love to say it's there tomorrow, but we're going to keep on with our plan of work. You can see the urgency that we have to move forward. So we will still go forward with the skill matching programme, so we'll have everything ready and prepared once the bill will come through.
Thank you very much, Dr. Kavanagh. Now, Deputy O'Reilly, thank you for your patience.
Thank you, Chair, and I'm conscious that our witnesses have been here for a while, so I'll try to be brief, but also I'm not brilliant at being brief, but I will try. Okay, so the point was made by Dr. Green that the staff do a fine job. They absolutely do. There's no question or doubt about that at all. The problem is there's not enough of them for all the people that need to see them. The issue is not with the quality of the work carried out by the staff. The issue is the fact that nobody can get in to get that high quality work. We talked a wee bit at the outset in relation to consultation. Okay, so this is a change in the model of care for children. So children's oral health, this is a change in how care will be delivered. So could you just talk me through what input TUSLA would have had in that, or in terms of the consultation? Were they part of it? Were they involved in the groups, given that it's a lot of the focus is on children's oral health?
Where TUSLA were, in regard to that, when we were when we were drafting the policy, we sent out the policy to all of the across all of the various departments, and then to all of the involved agencies. They would have been contacted through children and youth affairs, and the Department of Children and Youth Affairs, and that's where we would have got our feedback through them in that regard.
Right, and did they make submissions where they...
They were very positive about the policy, extremely positive about the policy, because all of the evidence would support a universal approach, particularly for low income and vulnerable, to be available as early as possible and as locally accessible as possible without them having to access it anyway. So, yes.
Okay, that's good. So there was no concern moving out of the current setting into a new model of care. They weren't concerned. There's no child protection issues or anything like that, or would they be, happy enough that they could be dealt with?
Dentists in accordance with dental ethics, if you're working with vulnerable groups and with children, you have to. Similar to any other profession.
So it would just be the same?
Yes, it's the very same. They hadn't entered. In fact, TUSLA of interest have in fact commissioned out are commissioning out work through practices at the moment in the south of the country. So that's in itself showing the confidence that they have in that.
That's good. Okay, can I ask a question with regard to emergency care? So the routine care, we know that the move is planned to phase that in. But with regard to the provision of emergency care, so you might just, even if you could give us some detail on what level of emergency care is provided at the moment. And obviously, if there's not enough routine care happening, clearly the bulk of it's going to shift to emergency care. That's not what people want. But what is the level of emergency care provided at the moment? And I mean, just even in terms of number of appointments, and how is this going to change? So in the new model, when fully implemented, when there's a flashing blue light emergency, where do you go?
So the system at the moment, if a child or vulnerable adult who attends the HSE dental service has symptoms, they would contact the clinic, or often might just turn up. We're recording in excess of 70,000 emergency appointments each year. Vast majority of those are children. A lot of them are actually very young children, 3, 4, 5, 6 years of age. A lot of them in a 5, 6, 7 year age group. Most of the issues that they have relate to decay in deciduous teeth or baby teeth. And with those, treatment can be either hopefully to restore the tooth. Perhaps you'll have to extract the tooth. And perhaps those, if there are multiple extractions indicated, or if infection has to be controlled prior to any treatment, a course of antibiotics might be indicated. If it's not possible to complete the treatment, or if multiple extractions are indicated, that could lead to a referral for treatment under general anaesthetic in one of the hospitals. That happens about 7,000 times a year. Okay, between emergency patients and then some patients who be referred without symptoms, but their treatment should be completed under general anaesthesia.
Okay, and how does that compare to other jurisdictions? I mean, to say Scotland or somewhere that would have a relatively similar population?
We'd be broadly similar.
Okay, so that seems like a lot, but maybe it's just...
It is a lot, but then dental care is a public health issue, clearly, and it remains a public health issue. Dental decay follows a socioeconomic gradient. We tend to see more in lower socioeconomic groups than in higher socioeconomic groups. We would obviously like for children to be seen at a much earlier age, and in particular identify those who are at the greatest risk of dental decay, or who may carry a risk related to a medical condition that would mean that treatment would be risky in itself, so therefore prevention is of even more value. And that treatment risk could also include some assessment of their risks of being treated under general anaesthetic or sedation. You know, you'd be seeking to avoid the worst possible outcome, worst possible treatment scenario, you know, where you're in a hospital for treatment for, as Professor O'Connell said, is largely a preventable condition.
Okay.
In a transition to a revised system, the HSE's priorities obviously would be to try and protect the strengths of the existing service, and that would be, you know, a same-day or following-day response for anyone who's in pain. Now, if the HSE service are involved in that, we will strive to continue to provide that, and that would be our plan. In any contracted situation, that would be an upfront requirement. But I would foresee that that mightn't be the easiest thing to put in place. So there's a starting point for all of that that we've yet to reach, and obviously there'll be extensive consultation with prospective service providers, with our own staff, with the department and any other stakeholder who would be involved. But it would be a priority to try and put that in place.
Okay, thank you. And just, I have some areas specific. Oh, my apologies, sorry.
Yes, just in line with the policy. In fact, when the ESRI were doing their model calculations in relation to emergency care, that was included in as part of all of the consultation, as part of all of the assessments in relation to it. So there's no question but that emergency care was included as part of the primary and preventive care bundle.
And the intention is it would be similar to what's offered at the moment?
Under dental council ethics, the person that's treating is also required under the dental council. And I think that's a very important statement to make, that if you are providing care, you must provide emergency care. Okay. So So it's not something for negotiation, it's part of their professional dental ethics, and let's be
Yeah,
completely
but
clear about that.
the issue being that it will be provided as it is, which is what, in 24 hours that the child will be seen.
You are required under your dental ethics to provide emergency services within a specific period of time. That's a requirement for every dental professional.
Okay.
To
What is it 24 hours or what's
It is within the appropriate period of time, but generally it is within 24 hours. But it doesn't have to be. If the patient, say for instance, rings in and the dental professional decides that it's not necessary to be seen because
Okay.
they're not under pain, that's a dental professional decision. But it's not a question of where it's best set or seated. It's part of your dental professional ethics. You must provide emergency
so
care.
when there is an emergency situation, care will be provided as appropriate to the...
And it must
Okay.
be from the dentist that patient is under that care. It's very clear in the dental professional ethics.
Okay, excellent. Thank you. Chair, I have two questions that relate to specific areas, if that's okay. So my first one, unsurprisingly enough, relates to Dublin Fingal, which is my own constituency. And the figures that we have via parliamentary questions show that there are, out of the 84,000 that are kids that are waiting, that 4,450 of them are in my own area waiting for longer than 52 weeks. So what it says on the PQ is that that basically that number is the number of children currently in 4th class, with no guarantee that they will be offered a screening appointment. Now, clearly that's very worrying. I happen to represent the constituency with the fastest growing population. Some people say in Europe, but definitely in this state, so that should be enough. There are large numbers of children. It is on a weekly basis that I see people in my advice clinics, parents who are concerned because their kids' teeth are deteriorating and they're stuck on waiting lists. And I'm not going, you know the figures, right? So I'm not going to go through every single one of the waiting lists, but the one that jumps out is that one in relation to kids waiting for more than 52 weeks. So that's a year. If you're due a test in 4th class and you have to wait a year, well, you don't need to be a genius to figure out you're not going to be in 4th class for at the end of it. So what happens to these kids? It's, by your own figures, it's highly unlikely they're going to get the screening. I know, because I talk to their parents, that, in many instances, the money isn't there for them to go and go private. And also, I say, why should they have to? Only that their kids are left waiting. So, what are the likely outcomes for those kids from missing that really important appointment? Presumably, it's important because otherwise it wouldn't be on the schedule.
Dealing with the 4th class question?
Yes.
Okay. The priorities the HSE set are to try and see children in 2nd class, 6th class and 4th class if possible. And there are a number of areas in the country where 4th class hasn't been reached due to capacity, as we discussed earlier. The amount of treatment, the increment of treatment that's often required at 4th class is much less if the child has been seen in either 1st class or 2nd class. And if I concentrate on permanent teeth for a moment, particularly if fissure sealants have been placed on the permanent teeth in either 1st class or 2nd class. Hopefully at that stage in 4th class, the visit would concentrate more on looking for the dental milestones such as the eruption of permanent teeth, the occlusion, and to reinforce preventive measures such as dietary advice, advice to parents, advice on toothbrushing, and also to just reinforce good dental attendance as well. Now, in the event the child's not seen in 4th class, the increment of decay that may have occurred between 2nd class and 4th class would be the one, obviously, that couldn't be treated at that time. Now, where possible, those children are followed up if resources allow. And then, obviously, they'll be seen in 5th or 6th class, depending on the approach of the local area. But as I said, the outcome of treatment at 1st or 2nd class would be critical. If it's the case that those children have been seen, thankfully a lot of preventive treatment would have been put in place, and that can help.
Okay, thank you. The reference here is to some staff shortages in certain areas across Dublin North in Balbriggan. Now, as it goes, and not only do I represent a constituency with the fastest growing population in the state, but Balbriggan is the youngest town in Ireland. So we are talking about a fairly easily identifiable cohort. I mean, you don't need to be a brain surgeon to figure out that if a whole lot of families buy houses and they are young families, the inevitable consequence of that, of course, is children. And the inevitable consequence of children is children's teeth. So notwithstanding the fact that a lot of this was predictable, there is a particular problem here in Balbriggan with the recruitment of staff. So have you any comfort for me to bring back to North County Dublin? Anything I can say to the parents?
I'll be in that area tomorrow and I'll follow up directly with you on what's happening at the moment. I do know that they had a dentist in Balbriggan who left the service just in at the end of January, and so I'll follow up with you on the replacement for that dentist.
Thank you.
And I do know that that whole CHO, Dublin North City and County, things are up to 15% increase in population, and it's impacting on our orthodontic service as well. You know, it's
one of those things that people should talk about before they start to build the much needed houses, but you know, where the services didn't follow. And I have a question on behalf of my colleague Kathleen, Deputy Kathleen Funchion, and it relates to the Carlow-Kilkenny area. So there's a couple of things in the PQ that we got. So the waiting times in Carlow and Kilkenny for more than 52 weeks. So it's 1,748 in Carlow, and in Kilkenny it's 2,181. Now, obviously, they're going to have the same complications as you have just outlined. That's one thing. But there's also reference made to a fire in St Dimphna's, which ceased dental services and the cancellation of surgeries for 4 months. So what is the current state of play for kids in Carlow and Kilkenny with regard to accessing services?
I don't have the information in front of me. My recollection is that services are back in place in Carlow, and that additional clinics were run in order to try to catch up the backlog in the course of late 17 and 2018. But
no, these figures now, I'm sorry to interrupt, but this PQ is from April 2019.
Yeah, but I follow through with the full picture on Carlow for you. I just don't know. But I do know that the fire was some time ago. But obviously the facility was out of commission.
This says for 4 months, but it's longer than that, I think.
Yeah, I'll follow through.
Yeah,
with the information for you.
And then there's also reference made to a current difficulty with the recruitment and retention of dentists in the South East community healthcare area. Yep. Do you have any insight as to why there is a particular difficulty there, and perhaps you might outline what efforts are being made to recruit?
I know that they ran competition last year, and at the point where someone was at contract offer stage, my recollection is that they didn't take up the offer.
Okay.
You know, so there have been some difficulties. Our process is quite lengthy, but it's very robust. And obviously things like Garda clearance and police clearance from other jurisdictions are part of that. It's just necessarily lengthened by those requirements. But I'll follow through with
and I know Dr. McLaughlin has indicated there were just on the issue of recruitment and retention. One of the things that was done in the broader health service, and Mr. Healy will be aware of this, is that they devolved the power. So look, the public appointment system is fantastic. It's very robust, and everything they do is above and beyond question. But it can be a little bit cumbersome. So you can have people who will get an offer maybe from a private contractor, and they can get a job in the morning, versus do you want to go through this really lengthy process where we really make you feel like we actually don't want to employ you, and then at the end of it, you know, that it becomes very difficult, and the system can sometimes make it very difficult. Has any thought or consideration been given to streamlining the process for recruitment? Because it has worked. I'm not saying it's fixed everything, but it has had limited success in other areas of the health service.
The rates now dealt with by the public appointments service would be consultants, dental surgeons.
So everything else is done locally
through the CHOs. And we also use panels as well. You know, if you have a competition, you create a panel, and we're trying to merge those across CHOs.
What's the current state of the panels?
A number of CHOs would have live panels.
At
the moment.
Okay, but not Carlow Kilkenny then, not the
I'll
South
follow
East.
through on that.
Okay, thank you. Sorry, Ms McLaughlin.
I just wanted to say that the questions that the deputies raised illustrate the problem for the HSE dental service very clearly and make the case for change.
But they don't make the case for privatisation.
Well, they make the case for change.
investment.
If you could contract it out, it's not. We can argue about the words, but
We can.
you know, I think it still makes the case for change, whatever the change.
No, absolutely, absolutely, 100%. Chair, that's
you.
my questions finished. Thank you.
Thank you very much, Deputy O'Reilly. So on behalf of the committee, we've been here for 3 hours now, so thank you very much for your time. On behalf of the committee, I'd like to thank you. On behalf of from the department, Mr. Judge, sorry we didn't get an opportunity to quiz you. Dr. Dimphna Kavanagh and Mr. Fergal Goodman, and from the Oral Health Policy Academic Reference Group, Dr. Alison Dougal, thank you very much for your input, and Dr. Jacinta McLaughlin and Professor Brian O'Connell, and of course from the HSE, Dr. Pat Healy, Mr. Pat Healy, and Dr. Joe Green. Thank you very much. So that concludes our business, and we adjourn until next Wednesday at 9 a.m. Yeah. Thank you.